meeting. Commissioners, included in your package are copies of the minutes from two commission meetings, the regularly scheduled February 15th public meeting and the February 26th meeting that was held by teleconference to address legislation before the General Assembly. I would like to entertain two motions to approve each set of minutes separately. Do I have a motion to approve the February 15th minutes? Is there a second? Second. All in favor? Any opposed? All right. Do I have a motion to approve the February 26th, 2018 minutes? Motion. Second. All in favor? All right. No opposed. Okay. Thank you very much. All right, commissioners, you have received from the staff written updates from all of the centers of the commission. You've had a chance to read these updates. Do any of the commissioners have any questions at all on the written updates generally, or for any member of the staff? No questions? Director, do you or any of the center directors have any additional updates for this?
Thank you, Mr. Chairman. I have one update. As some of you know, legislation is moving through the Maryland Senate and House that would stand up or sustain the individual market and insurance exchange in 2019 and beyond. The Commission has shared our all-payer claim database with Hilltop, who is working with the exchange staff to develop some estimates on the magnitude of the reinsurance pool that would be needed to support the exchange. Currently, there are several proposals. All of them focus on establishing a reinsurance pool, which would provide funding for insurance costs above a certain threshold. The first bill has, which would be really a temporary fix, would provide for 1-year funding of a reinsurance pool through a premium tax on all Maryland insurers, both in the commercial market and the MCOs. That's thought to generate about $300 to $350 million, which is judged adequate for 2019. A more broader bill, which focuses on directing Maryland to apply for what's called a State Innovation 1332 waiver to the federal government, is also working its way through the legislature with broad support. No action, final action on that as of yet. It's hopeful, given that both the administration and legislative leadership is behind it. 1332 waivers have been implemented in a number of states. They provide for a great deal of flexibility. What Maryland would be doing is using it to establish a permanent reinsurance pool and using some of the federal pass-through dollars that would be available because we changed our individual insurance market, and taking money that the federal government would pay if the reinsurance pool did not exist for advanced payment tax credits, and repurpose that for the reinsurance pool on the assumption that premiums are lower and therefore the APTC subsidies would also be lower. No final action is been taken on that. We have 3 weeks left, but it's safe to say that that is the highest priority legislation, I think, before both the House and Senate at this point. There is significant concern on the stability of the individual market in Maryland in 2019, with estimates of significant premium increases absent no action on the part of the legislature. The commission would likely be called upon to support some of these activities going into the future through our development of the all-payer claims database, but that has not yet been fully spelled out. Our role up to this point is simply making information that we have available, and we'll keep you informed as these actions move forward. The emergency one-year fix looks like it will succeed paths first, with the longer-term bill considered after action on the truly emergency bill.
Thank you very much, Mr. Director. I just simply emphasize to the Commission that the legislature's action in this area is really quite critical for the health of the individual market. There seems to be a general consensus among Democrats and Republicans in the state legislature that we have to do what we can to stabilize that market. And I would just mention that through the 1332 waiver, the option of getting a more flexible regulatory regime and being able to repurpose funds can actually have a pretty significant effect on premiums. Just in one case, and it's not the best example because it's a very, very unique state, but Alaska was faced with a very similar problem with their individual market. They repurposed funds to develop a risk mitigation pool, reinsurance pool. The consequence of it was that they were able to reduce premiums in the individual market by about 25%. So this is a serious matter, and anything the Commission can do to assist the legislature in this area is going to be a great public service. So thank you, Ben. Thank you very much. Ladies and gentlemen, the next issue before the Commission is an application for a certificate of need for the Thomas Johnson Surgery Center. The Thomas Johnson Surgery Center applied for a certificate of need to establish an ambulatory surgical facility through the conversion of a non-sterile procedure room to a second sterile operating room. This is going to take place at its existing facility. It's a physician-owned facility. It's a physician-owned ambulatory surgery center. Kevin McDonald, Chief of the Certificate of Need Division, is going to present to us the staff recommendation. Yes, present. What do you want to do?
Thank you, Mr. Chairman. Good afternoon, Commissioners.
I don't want to prevent anything. One thing to move ahead.
Mr. Chairman, before we start, I need to recuse myself.
Very good. Have it noted that Commissioner Fleig recused himself.
Okay, as Commissioner Moffitt noted, the Thomas Johnson Surgery Center is a physician office surgery center now, one operating room and one procedure room, and with this application, it would become an ambulatory surgical facility and thus subject to certificate of need with the two operating rooms. The facility is owned 65% share owned by SCA Frederick LLC, which is a subsidiary of Surgical Care Affiliates, which owns 4 other surgery centers in the state of Maryland. The remaining 35% is owned by the physicians who operate at the center. The estimated cost of the project is about $183,000. The applicant plans to put $25,000 in cash and borrow the remainder. The applicant is licensed in good standing with the Maryland Department of Health, is in compliance with the conditions of participations with Medicare and Medicaid, and is accredited by the Association for Ambulatory Healthcare. The plans, the design for the facility is consistent with the FGI guidelines, including selecting proper finishes to maximize the ability to sanitize the space, adjusting the ventilation system to meet or exceed required air exchanges in the ORs, and designing the second operating room to be identical or similar, at least, to the existing operating room, which minimizes training requirements and opportunities for error. And finally, under the quality and safety provisions, the applicant has a transfer agreement with Frederick Memorial Hospital. Looking at the need for the facility, I think the commission is at this point pretty well familiar with our optimal utilization guidelines, which is 80% of operation at 8 hours a day, 255 days a year. The facility reached optimal capacity for a single OR in 2014 and 2015 and projects demand for operating room to grow to volumes that would be equivalent to 1.8 ORs during 2018 and to 2 rooms by 2020. And that growth is based on the knowledge of the existing physician practices, the trajectory of their volumes, as well as the recent addition of an orthopedic surgeon and the imminent addition of 2 more orthopedic surgeons. In addition to the boost to the number of cases that they would bring, those cases would also be increasing the average time per procedure. Looking at the viability and financial feasibility, the facility showed a healthy margin of about $4 million annually the last couple of years and projects significantly improving that profitability after implementing the project. The financial resources to implement the project are available to the applicant. Looking at the impact on the existing providers and the health system at large, the projected impact on Frederick Memorial Hospital is about 4.3 to 4.4% of the hospital's total surgical capacity, which is well below our threshold of 18%. Looking at the charity care provision, charity care standard, as a physician office surgery center, the facility did not have a charity care requirement and appears to be a negligible provider of charity care in that capacity. Going forward as an ambulatory surgical facility, it will have a charity care obligation, which it has accepted. It provided a policy which is consistent with the charity care standards requirements regarding a 2-day determination of probable eligibility for charity care, the notification requirements, and the eligibility requirements. I would also note that I was particularly impressed with the charity care compliance plan that they submitted along with the charity care policy. Among a number of proactive measures, it includes a monthly management report that is made to the board of directors and the personnel in the facility that would track that performance towards charity care and would trigger outreach to a number of agencies and organizations likely to be in contact with populations needing such assistance. In summary, the staff concluded that the relevant state health plan standards have been met and that the criteria in COMAR 102401 have also been met and recommends approval. Here from the facility, representing the facility, is Naomi Allen, the Chief Executive Officer, Jack Eller, their attorney, and Andy Solberg, their consultant.
Thank you very much. Thank you, and welcome to the commission, Naomi. Thank you, Kevin. Commissioners, are there any questions for Mr. McDonald? Any questions? No. Okay. The issue then before the commission is an approval of the certificate of need for the Thomas Johnson Surgery Center. Do I have a motion to approve? Second. We have an approval. We have a motion, a second. Is there any further discussion at all on the proposal? Yes. Director?
Just one question that Commissioner Pollack has referenced several times is the challenges that AFCs have in participating in the Medicaid program. Out of curiosity, Kevin, does this facility participate with Medicaid MCOs?
with Medicaid.
Managed care organizations.
I would have to defer that question to the applicant.
And how many?
Any further questions? Okay, the issue is on the motion to approve. All those in favor say aye. Aye. Any opposed? Very good. Thank you, Kevin. Ladies and gentlemen, you have your certificate of need. All right, ladies and gentlemen of the commission, ladies and gentlemen of the public, we are updating our state health plan for cardiac surgery and for cutaneous coronary intervention services. The commission staff posted draft regulations, COMAR 10/24/17, of the state health plan for facilities and services in the area of cardiac surgery and for cutaneous coronary intervention services back in March 1st, 2018 for informal public comment. These are draft regulations. They were developed in consultation with the Cardiac Services Advisory Committee. Eileen Fleck, who is the Chief of Acute Care Policy and Planning, will present the draft regulations. Ms. Fleck.
Thank you. Good afternoon, Mr. Chair and Commissioners. The key changes to the State Health Plan chapter for cardiac surgery and PCI services that I will be describing for you are covered in the memo that has already been sent to you. The definition of cardiac surgery has been revised based in part on a reevaluation of the ICD-9 procedure codes that are used in the identification of cardiac surgery cases. Recommendations from the Maryland Cardiac Surgery Quality Initiative, a consortium of all 10 Maryland hospitals with cardiac surgery programs, were used to inform the discussion of these codes by the Standing Advisory Committee for the Commission, which is the Cardiac Services Advisory Committee. So the Maryland Cardiac Surgery Quality Initiative's recommendations included a list of procedure codes that are not defined as cardiac surgery, but that it recommends only be performed at hospitals with cardiac surgery programs. These codes are noted on page 13 of the draft chapter that was posted for informal comment and are in the appendix of the draft chapter as well. The members of our Standing Advisory Committee agreed with this recommendation, and all of the corresponding ICD-10 codes are excluded from the definition of cardiac surgery. In conjunction with changes to the procedure codes used to identify cardiac surgery cases, the definition of open heart surgery has been removed. References to open heart surgery in the standards used to evaluate certificates of ongoing performance and certificates of need applications have been replaced with references to cardiac surgery. The use of the term open heart surgery as used in the chapter is confusing because it includes procedures that traditionally would not be considered open heart surgery, and so the term cardiac surgery is more accurate. In the current chapter, the term open heart surgery is also used to refer to a subset of cardiac surgery cases that count for volume standards and in utilization projections. In the draft chapter, we've used a different approach for identifying which cases count for the volume standards and those utilization projections. We have a definition of case that's been added to the chapter, and there's an appendix which lists which procedures are identified as cardiac surgery cases. In terms of the patient outcome metrics for certificates of ongoing performance for primary and elective PCI services, staff has suggested changes in order to allow for the use of more timely data that is more readily accessible. The current standards reference all-cause 30-day risk-adjusted mortality rates for elective PCI cases and primary PCI cases. The source for the 30-day mortality rates is the Center for Disease Control's National Death Index data, which lags by about a year and is released for calendar year periods. So as a result, the most recent data available for undertaking ongoing performance review could be 2 years old. In order to obtain more timely information on the patient outcomes, the draft chapter revises the applicable standards to reference in-hospital mortality. That's something that is readily accessible in the data that we have now. Members of our Standing Advisory Committee are supportive of this approach. Another change that staff is proposing regarding the patient outcome metrics for PCI programs is the use of the national average rather than the statewide average when the statewide average is not timely available. This is because the current risk adjustment model developed by use for the American College of Cardiology is appropriate for national comparisons, but it cannot be used for comparisons of hospitals to a statewide average. Potentially, a new risk adjustment model can be developed to allow for that comparison. However, in order to avoid further delays in the review of hospitals' applications for certificates of ongoing performance, staff is recommending that the draft chapter include an alternative benchmark that is readily available, which is the national average. Members of our Standing Advisory Committee expressed support for the national average, and several of the members actually support using just the national average because they believe that it's statistically superior, it's simpler, and it's more cost effective. However, at this time, staff is recommending that we adhere to recommendations from the clinical advisory group that included experts from outside of Maryland, and whose recommendations became the basis for the current standards in the chapter that are used to evaluate applications for certificates of ongoing performance. Staff is proposing changes to one certificate of need standard, the financial feasibility standard. The suggested changes are needed in order to be compatible with changes to the payment model for Maryland hospitals. The current policy is adopted by the Health Services Cost Review Commission regarding the handling of market shifts, and the adjustments made to global hospital budget revenue as a result of these shifts are not compatible with the requirement for a short-term standalone profitability requirement for a new cardiac surgery program. In the current chapter, the standard provides that within 3 years or less of initiating a new or relocated cardiac surgery program, the program will generate excess revenues over total expenses for cardiac surgery if utilization forecasts are achieved for cardiac surgery services. So this language has been removed and replaced with language that requires an applicant to demonstrate that the proposed cardiac surgery program will be financially feasible and will not jeopardize the financial viability of the hospital. The last change that I want to mention is that the standard for institutional resources, which is one of the standards used to evaluate certificates of ongoing performance applications for primary PCI services, has been revised to clarify the requirements, including reporting on lapses in service availability. Hospitals are required to have primary PCI services available 24 hours a day, 7 days a week, but sometimes compliance with the standard may not be feasible, and the revised standard acknowledges this possibility. The draft chapter includes language that explains when and how a hospital may be granted a temporary waiver from the standard, and the revised standard also provides that hospitals are required to record lapses in service availability, and upon request of commission staff provides this documentation. For all of the suggested changes to the draft chapter, the staff will consider the informal comments submitted, as well as recent feedback from our Standing Advisory Committee. The informal comment period will close on March 26th, and we plan to evaluate the comments received and then request action on draft regulations at the next commission meeting. That concludes my presentation. I'd be happy to answer any questions.
Thank you very much, Ms. Fleck. Commissioners, are there any questions for Ms. Fleck?
A couple of different points. One, in terms of in your document on policy number 1, you talk about the services will be provided in the most cost-effective manner possible. Now, in health economics, cost-effective is a very specific methodology, and I don't think you're asking for that. Cost-efficient might serve your same purposes without raising any confusion between that you're asking for a calculation of the natural history of the disease and the quality effects of on quality of life and the other things that are associated with cost-effective measures.
Okay, so cost efficiency.
If that still meets your needs, I tend to think in most times efficient versus effective is grammatically somewhat different. The A-bomb was effective. I don't know if it was an efficient, boom, so in those sorts of things. But if it meets your needs in terms of the sort of tone you wanted to set here, it would avoid this confusion with sort of this whole subfield of health economics that deals with cost-effective analysis, and it has all these extra meanings to it.
Okay, we can take that into consideration.
Okay. I had another, if that's all right?
No.
So anyway, I just missed it a little bit in terms of when you're going through the idea of when you were talking about the risk adjustment, and there was risk adjustment data, and then there was risk adjustment methodology. And so on some of it, it sounded, if you can elaborate a little bit on there. I didn't know whether we were talking about that at one point, and certainly correct me if I've got this wrong, you were saying, well, we don't really have Maryland data yet, so we're going to use a national average or the medians or whatever you're going to do in order to be able to do that. I didn't quite get, and that seems straightforward, but I didn't, if I got it right, but I didn't quite get whether we're using you had said something also about kind of a new risk adjustment methodology sort of needs to be developed. And I didn't know whether we were talking, is Maryland asking for its own methodology as well as its own data? Or is there just not a national risk adjustment methodology that like CMS uses for Medicare? So I just wanted a little elaboration. Is it data versus method? Is it Maryland versus the country? And how does that break out?
So all the hospitals participate in the American Cardiac, the ACC's CAS PCI data registry, and so many hospitals across the nation are participating. All the Maryland hospitals are participating, and they give hospitals feedback on how they're doing, and that's a national benchmark, and that's what every hospital gets feedback on, how you're doing compared to a national average. And so their risk adjustment models are valid when you're making the comparison at that level, but when I talked to them, they said that it was not something that they could use to have a statewide average and then compare individual hospitals to it, that a new model would need to be developed in order for that to be valid in their eyes. And so,
so these payments are Medicaid, Medicare payments. Who are we risk adjusting for, or are we just in terms of how well a particular facility is doing? Are we risk adjusting?
it's for all of the patients who are in this data registry
Okay,
getting PCI
but it's not. Originally risk adjustment was developed to adjust payment. Is this more you're giving them a kind of a scorecard of giving you have a harder?
Yes, it's all about performance and having that feedback and knowing how your program is doing compared to others.
So what some of us might think of, the older of us, who might think of as a kind of a case mix sort of a methodology that, you know, if you're doing all the really hard ones, that should be taken into account appropriately, that you're going to have a higher death rate or whatever because you're taking harder cases. Okay, so that in terms of, so that's the kind of methodology we're talking about. And what is the logic that says that somehow cardiac and PCI services are unique in Maryland compared to the rest of the country?
Well, so we had this clinical advisory group that was formed back in 2012 that had the people outside the state, and they made recommendations, and they felt that using the statewide average would be best. And so that became the basis for our regulations. Also, on the cardiac surgery side, at least, like some of the programs did also feel like, well, why not just use the national average? But for that registry, they don't want us using the national average. They want to keep that information proprietary. They don't want hospital sharing with anyone. It's strictly for quality improvement. And so they feel that if someone wants to use a statewide average and all the hospitals participating are willing to share that information and they will generate statistics, that's fine. For the ACC, the CAS PCI registry, they are willing to let us use the national average. I did confirm with them that that was a choice.
Okay, so who is it who does? So I'm just trying to drill down a little bit here. Are we talking about that it's access to data, or that there is something that really, in terms of when you think about how this care is provided in Maryland, that there's something unique about Maryland? Or, I mean, I don't think of us as being quite, you know, they talk about kind of the bypass belt or whatever. You know, I mean, we're not a particularly sicker state or healthier state, or we don't practice medicine.
Well, we're different.
I mean, unless that's what they're saying, that really we do it differently here than we do it in DC, Virginia, Delaware.
I think that there was a concern that we are different because we now have this external peer review requirement. And so there is that extra check in terms of appropriateness of PCI that you don't necessarily have in most other places. So I think that was part of the logic, and that we would be auditing the data. And so it seemed more fair to Maryland hospitals if the environment is different to just use a statewide average, is my understanding.
Okay. I guess just thinking as a guy trained in statistics, that to go to a smaller N is typically not going to improve your accuracy. And it is going to leave this, if you had an outlier one way or the other, it's much more likely to give you very disruptive kind of effect, either too high, too low, et cetera, et cetera. So to go to a small sample over a large national sample would take somewhat more extraordinary justification. Normally, I'm more than willing to consider that I'm somehow missing something here. That's one. And the other thing is to develop a whole new, if you already have a methodology that is considered fairly accurate, to develop a new one uniquely for Maryland, because if nothing else going to cost is a delay. I mean, who's going to do it? Who's going to pay for it? I mean, they're normally fairly, you know, I mean, because if you don't do a fairly rigorous sophisticated job, you get a lot of people mad at you because they're telling you good guys are bad and bad guys are good and everything else. So this idea of saying we need our own, I have to say on a couple of different levels, it's just suspect to me. I mean, I'm open. I can be convinced, but it wouldn't be my default position to say because an advisory board thought we were special, but they can't really tell us why we're special. I mean, we sort of heard that from hospitals for a long time, and Leapfrog had something different to say about that.
Right. I mean, I would say that, as I mentioned in my presentation, members of our standing advisory committee did bring up the point about statistically they think it's superior to use the national average, and they had some concerns about that. And they understand that this is that it's more costly to develop a model. So there are some of our members definitely felt like maybe we need to consider this. We felt like, well, there was this other group, and these are the basis for the regulations. But in the short term, that we would be using the national average. That is what's available to us in a timely manner.
Commissioner Pollock.
I just want to say I had the same concerns in reading through that, but my understanding is that your intention is to eventually use both the national comparison and the Maryland comparison, and I don't have a problem with that. That's just additional information. I'm not sure how you'll ever get to the level of statistical power associated with with using the national benchmarks. But if the Maryland benchmarks show something different, then they show something different. And I think we're at least forced to look at that and try and understand what the difference is.
Then
If it's more than just power.
it's a friendly follow-up. Who is going to do the Maryland-specific methodology, and who's going to pay for it?
I just want to make sure my understanding of that's correct. Your
Well,
intention is to use
actually,
both.
the way
I may have been mistaken.
I understand it is that we would first prefer to use the statewide average, but when that's not available, then we use the national average. I would say that we do have access to the national average information or something close to it, essentially because we have the reports from the hospitals where they have the benchmark information across a whole range of.
I concur with Commissioner Brady that the national benchmark has to be our primary benchmark, regardless of what the outside recommendation was at the time, 6 years ago.
Okay.
That's fairly definitive. Commissioner Thomas.
I thought I was done.
No, you're not.
But,
You're never done, Commissioner.
I think it's an interesting, challenge that you're describing. And so my question is, in the process of the deliberations, did they take into consideration how the national average might obscure disparities, or is that being taken into account? The diseases you're talking about are disproportionate in certain subpopulations. When you average it on the national basis, does it obscure the racial ethnic disparities? Is there an unintended consequence that they were sensitive to?
That didn't come up as a discussion point among our members. I mean, I think the way we're using it, it's kind of focused just at the program level.
So all I would say is this, because it's not uncommon that it doesn't come up, and that is, I want it to come up.
Okay.
So the next time you're in a room like that, to say that this question came up, I want to either rule it in or rule it out, but not just to assume that it's, methodology neutral, because it is not. And in that context, Maryland is a very diverse state. So, that's all. I want to know that they were sensitive to the issue. They at least discussed it, ruled it in, ruled it out, talked about how it might impact disparities in subpopulations when you use a national average.
Right. I mean, I think it is challenging because we don't know the statewide average. We don't have numbers on that, right? And so it becomes sort of this abstract discussion. And I think to some extent that was an issue just for the state versus the national, where it was sort of speculative, like, well, what will it really look like? We're not sure. How does this look? But
and as Commissioner O'Grady mentioned, there are other, the National Academy of Sciences or other groups trying to figure out this risk adjustment, not just in the area of cardiac, but more broadly. And I'm hoping that those methods and those reports are also a part of the deliberation.
okay, thank you.
Mr. Chairman?
Yeah.
One thing I would say, which I hadn't thought of until you brought it up there, is that that's another argument for why you would want national data. That as any of us who have wrestled with sample size, and I'd like to be able to say something about this subpopulation or that subpopulation, but I just don't have the statistical power to say anything definitive. You want that, once we're talking about any group that is less than maybe 10% of the population, which most minority groups, Hispanics are about 15 now, blacks are at about 12, that kind of thing. You want that broader sample so you can say something smart and definitive about, are there any differences here? Or is it just small numbers and we can't tell whether there's anything really going on here? So that would lean me in general, knowing nothing else. And I know I don't in any way want to demean the deliberations that have gone up to this point, but I'm just looking for the most rigorous data we can have that allows us to be able to know these things the best we can and the best methodology. And I have to say that after some of our experiences over the last year or so, people saying Maryland is special and somehow we don't do things that, so we should be treated differently, measured differently. I'm not as sympathetic to that call as I was maybe 6 months ago, when we've seen some of the actual how these things have worked out in practice. Meeting national standards would probably be pretty good, in my opinion, if we can.
Mr. Director,
So, I think the way the draft regs are crafted, they do spell out use of a statewide average, but national average would be used if the statewide is not available. What is clear about this developing a statewide measure is that we don't have access to detailed level data that would be necessary to develop these at the present time. To Eileen's point about the model, I think we will have to spend money from our precious dollars to test this model. I would think the starting point for any vendor that would undertake this effort would be to use the national model and confirm that it's appropriate for Maryland to begin with. And I think then we would make that determination with not only the clinical advisory group, but commissioners bringing back that result. Now it's time to go to the statewide model. I think we do, and I think most everyone here, save Commissioner Flagg, was not on the commission, but we convened a national panel of experts that advise us on how we might do this ongoing approval process for these programs, and it included leading representatives from the ACC, leading representatives from the Society for Thoracic Surgery, both inside and cardiac and cardiologists, both inside and outside the state. And I think we should at least consider that. We're not saying we're going to immediately go to this, but we should leave it in the regulations so we have the opportunity to begin to investigate that option before we simply abandon what, I respect our clinical advisory group a lot that we have today. I respect the nearly 14 months of work that the other group did and the travel that people came into the state to give us advice on. And I think that's where we are. I think what we heard from many of our clinicians was, go ahead and if the national results are known, and in fact, it's possible that the state results in this particular case could set a higher standard than what the national results, national average would yield. And we, after some discussion internally, think that's at least a way to send out the proposed recommendations, regulations for comment might be that we're recognizing there are significant hurdles. We have a process in place that will use the national benchmarks, the national averages to start with, but allow and signal to the industry that we want to study it further. I think everyone in our group knows where they stand on the national measures and is quite comfortable, and in fact are doing well, and that should instill some confidence that anything we would develop, I think, would be information that we garner before we make that decision. So,
Commissioner Pollock.
The language you just described then is a little bit different than the language in the draft regs. That language says that we would use either both, or if the state benchmarks were unavailable, we would use the national. And I would support the language you just described, which is that we use both. And if the state sets a higher bar, then we use the state benchmark preferably. But I think the idea that we would abandon the national benchmark at the point when we have a state available is troublesome for the reasons outlined by Commissioner O'Grady.
Commissioner Sargent. Commissioner Sargent.
This is not my area, and I read the draft. The way I read the benchmarks is if you don't meet the benchmark as written for the state average, you get a focused review as a result, right? And that goes through and looks case by case to see if the case was handled appropriately.
Well, I think it depends on what the findings are, but yes, there would be further investigation to find out what the causes might be.
In a way, it might be also a resource issue of how many, if we're looking at the bottom half under a focused review, or do we look at the bottom quarter? It might be that we want the average of the people before us to figure out how many focused reviews we should be doing or can do. I'm not sure it's purely a determination of what the standards should be medically as much as also a when are we doing this more focused review.
So it's not a single number. It's not going to be, we know for sure half are under a statewide average. There's a confidence interval. And so to the extent that people are pretty similar in their performance and the uncertainty is wide enough, like with our cardiac surgery programs, where there's a kind of a similar benchmark in that you've got the statewide average and everyone's compared to it, and no one was outside of the confidence interval. No one is considered performing below average enough that it's a concern.
So there's sort of like basically a band around the average.
Yes, there's a range basically, so that we avoid this problem of we wouldn't want to have an automatic every year half the people are below average, and we're doing a lot of investigating.
Commissioner O'Connor.
Correct me if I'm wrong, but is PCI considered cardiac surgery?
No, they're considered separate.
Yeah, I have trouble dealing with that. So the more technologically advanced we get, the less open surgery will be, harder to meet the standards that you're recommending. That's like saying a vascular endograft put in percutaneously is not surgery in the aorta. I mean, it's.
I would say that people have raised the issue that cardiac surgery is changing and that maybe more of the procedures are percutaneous, but we have a definition of cardiac surgery, and then we have PCR, so they are distinguished, and in each case there are performance benchmarks. So in both cases we are looking at the outcomes and the performance of programs.
I'm just concerned about institutions needing the benchmark with less and less open surgery being done.
I think that we don't have that concern at this time. Like we have, in some sense, I think, added to what's labeled cardiac surgery, maybe compared to the current chapter. Most of the programs are well above 200. Really, the existing ones have to be above 100. That's sort of more of the cutoff point. Like ideally, they're at least at 200, but 100 is more of the cutoff point, and I don't think there's really any disagreement that that's completely reasonable. It's a pretty low number.
Well, a corollary to that would be, so aortic endograft, if it's placed percutaneously, is not considered vascular surgery. Just like you do cardiac surgery through percutaneously. You place an aortic graft percutaneously, that's not going to be considered vascular surgery.
I can't answer that question.
So in cardiac surgery and PCI, the definitions are pretty clear as to what procedure goes where. And I think the purpose of this change in definition was to specifically allow things like TAVRs and valves that are done percutaneously to be included in the definition of cardiac surgery. So it addresses exactly the point that you're making. But you can't have an entire program without any open trying to understand exactly the point, but I think what you're saying is, could you have a cardiac surgical program that met the entire definition through just percutaneous procedures without doing any open procedures?
No, just the opposite. The more percutaneous procedures done takes away from the open procedures.
Right. That's what I'm trying to. I think that maybe I didn't say it right, but that's exactly what I'm trying to say. It's would this change in definition to cardiac surgery allow you to have an entire cardiac surgical program without ever opening a chest? Right. And that would potentially be dangerous. It would be a different level for us to get into. But I think there are specific minimums in each of the categories. Aren't there? You have to do a certain number of cabbages.
Let's say 200.
No, I mean it's cardiac surgery, and everything is cardiac surgery.
So if you do 200 percutaneous valve procedures, if we add percutaneous valves into the definition of cardiac surgery, and you did 200 percutaneous valve procedures and never did a cabbage, that would be considered a zero. Would that be considered a viable cardiac surgical program?
I feel like I'd have to know the codes they're talking about. Like I would look at our appendix and look at what it says in our appendix about percutaneous valves.
If that's the case, I would concur with Dr. O'Connor's concern there, because you shouldn't be able to have, but the problem is there aren't that many percutaneous valve procedures out there to be able to do that. That would be a theoretical that would be hard to get to, but that would be a concern. That it would be getting us into a new territory. Sort of, we went to PCI without cardiac surgical backup. We did that very deliberately and in the context of very specific assessments of risks and benefits. And this would be moving us into an area where we're establishing cardiac surgical centers that do no open cardiac surgical cases without that same rigorous level of review first. So I hadn't thought about that until you brought that up. And I think it's a very remote risk, but it's probably something that we might want to consider addressing in the regs. Open procedures. We're changing the definition from open heart to cardiac, but traditional open procedures need to remain a significant portion of what's being done in order to have a cardiac surgical program.
I mean, we did talk about this issue in terms of like, do we need to have subsets and what's necessary in terms of the skills? Like, would it be okay if someone was doing lots of ECMO and that was like the bulk of it, if ECMO is considered cardiac surgery and counts for volume, which it doesn't in what's been proposed here. But there were some discussions.
Not correct.
It's not, right. But there were discussions around that issue, right? When people were saying, well, what does this mean? What if, so I feel like the group did consider that idea that what if someone is just doing a lot of this type of procedure, like what does it really mean in terms of the skills of the surgeon that need to be maintained and what we should be calling cardiac surgery? I feel like they really considered those factors. It's not possible for me to like respond to the general description of like percutaneous valves and feel like I know exactly what you're talking about. I have to really look at this list of codes and what we said.
Is the group disbanded now, or is there a way to go back to that group and ask that specific question?
The group, it's our standing advisory committee, so yes, we can get additional feedback from them on that issue. I do feel like they took that into consideration when we were defining cardiac surgery and what it would mean if someone was really heavy in one area or in a different area. We spent a lot of time on this, truly we did, and they really considered this carefully in terms of having criteria, the clinical criteria for what's cardiac surgery, and I feel like I exhausted them. To me, that's what I wanted to know.
The expert group that we convened considered that exact issue and didn't feel that there was a problem, and that they can articulate exactly what the answer was. So if the answer is you can do all percutaneous TAVR procedures and still have a viable cardiac surgical program, we would want to know just like a paragraph on why. Yeah.
I think
so.
I don't think so.
But they're not considered cardiac surgery though, if it's done percutaneously. This whole list here says no, 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 no.
Right. I mean, that was typically like percutaneous was seen as that's not going to be cardiac surgery. That was sort of a general rule, I guess you could say, for this group. That was pretty consistent. Like, it's percutaneous, we performed, it's not cardiac surgery.
You're crossing over specialties too. Radiology does a lot of them. So.
Director?
So, yeah, I think the question that Commissioner Pollock raised, could we have a cardiac surgery program that only performed percutaneous procedures? I think that was wrestled with philosophically among the 20 odd members of the group, and operationally today that does not come close to being characterizing any program in Maryland today. I don't know if I'd probably venture to say any program in the United States, but there was a recognition that the fusion or the technology evolution is that more and more procedures are performed percutaneously, but there was a strong emphasis, if you will, from a layman's point of view, that open procedures were an essential characteristic of a viable cardiac surgery program, and those were essential skills that cardiac surgeons had to have to operate in a cardiac surgery program here in the state. I think the questions, we're seeing the evolution of these protocols, and everyone agreed that there's more and more opportunities to perform closed procedures, which is going to raise questions not only for care but also our oversight authority. But I don't think we're anywhere close to that just yet. But how fast things are changing is just to look at how the diffusion of who's performing TAVR in the state has changed over a couple of years, whereas 3 or 4 years ago there were only only the academics were performing it, and perhaps Union Memorial. We've seen the adoption of that at virtually every cardiac surgery center today, say 1 or 2. So technology is changing. The ability of hospitals to offer this safely is increasing. So the questions you're raising, I think, are ones that we're going to be monitoring with our ongoing group as we move forward with what we have now. I think one of the things that we do want to emphasize is that we are changing this so we can start this process of ongoing review. We were directed by the legislature to do this in legislation that was passed in, I believe, 2012, 2013.
Around there, yes.
Yes, and for the getting the clinical groups together, convening them, developing regulations, and then aligning the data sources has been a labor-intensive process, but one I think that Eileen's done a great job leading and bringing together 20-odd cardiac surgeons and cardiologists in building some consensus is not a task that at 8 o'clock at night or 6 o'clock at night, when the food is sparse and the evenings are dark, is challenging. But I want to thank her for that.
Thank you.
Are there any further questions?
Yes, I have a couple of clarifying.
All right.
One in terms of, I liked Ben's language, but I would like to tighten it up a little bit. On the idea of when we look at the next round of this, I would like something along the lines of default to national measures and methodology, and we'll consider state-specific methodology. It will be considered by the commission at a later date when available, something like that. So that was, I just like a little tighter in terms of that the development of a state methodology cannot be a delaying tactic. You're going to be, we have the federal data, we have the federal methodology. That's what it's going to be. If we have something better later, happy to look at it. But it's not quite the or. It's more we do one, and then if it becomes available, then we'll consider doing both along those lines. The other thing was Commissioner Sargent's point. So the idea there of standard deviations, this distribution. So what you really want to do is you don't want to get somebody who really there's no difference between, they're 10% lower than the average, but that's really just random. That's just in the methodology and whatnot. So you go out a standard deviation or two, and that's when we talk about statistically significantly different. So it's more than random. The likelihood this is random is less than 5%, is normally what is used as a standard. Now, that sounded like the kind of methodology you were considering in terms of triggering these more serious reviews.
Yes.
So so you're looking at probably, if everything is random, which of course, it's just a construct, it never really is there except flipping pennies, but everything else is a little off that. But you'll probably look at about 5% a year that you're talking about then? Or even less, maybe 2.5, because it's 2 standard deviations in either direction. I mean, somebody's going to be exceptional in this and will be as far ahead of everybody else, theoretically.
I think it's possible that we may not do any reviews, like I said, on the cardiac surgery side, because the performance is close enough and they're all satisfactory, and given the uncertainty of it, like for it's maybe 2 or 3 intervals that I have, the cardiac surgery statistics, and that is using a statewide average, there's no one who is considered, I guess, up for a focused review who's below our standards. Everyone is doing fine.
So is that a judgment call on the commission and the executive director, or is that, do you want something that is a particular measure, 2 standard deviations off the national average, let's say? So you know that if everybody in Maryland's doing great, don't pick somebody out because they're the least great of a group of great programs.
It is very specifically defined, so it is the 95% confidence interval. There's not like a judgment about it. This is what the calculations are that we were given, and so either you're getting a focus review or you're not because you're doing fine based on the calculations.
Okay, so if you're in that kind of, you're at the bottom, you're in the tail of the distribution, your 2 standard deviations out. At this point, you would get an automatic review, but it may be not as concerning because you realize. I mean, how do we do? Are you saying that the review is automatically triggered if you're below 2 standard deviations?
Yes, I mean, I think you could look at it that way. Yes, like we will look at things more closely. We will have clinical experts to evaluate how the hospital is doing. There is a little bit of a lag with this, so there may already be or may soon be more information on how the hospital is doing, which could also be a factor.
Further questions?
Yeah, I think that's fine. I mean, what I'm hearing here, just to reword it so I understand it, is that the kind of the trigger analysis is the 2 standard deviations. Then you'll look at it, and it's not like somebody's found kind of out of compliance just from the statistics. Then you take a look at them. That triggers sort of this extra look. If you find that, yeah, it's 2 standard deviations, but it's really not that much different than what other people in the state are doing, it's a quick, it's an easy, it's wrapped up, and you move on. If it is so you're doing a 2-step. You've got what I used to call in the old days, you have kind of a target analysis that's done using statistics, and then you have the actual case by case, which is human beings looking at the records and making decisions about whether there's a problem here or not. Is that the methodology?
Yes, exactly. We didn't want anyone to be automatically penalized.
Yeah, right. You're not found out of compliance by statistics.
Right.
You're targeted for a closer look by statistics.
Right.
Got it.
If there are no further, what is one more? Go ahead.
One more comment.
Dr. O'Connell.
I think I have difficulty breaking out cardiac surgery. I think cardiac surgery, and I think it's confusing here. You're equating cardiac surgery with open heart surgery. I think cardiac surgery is done either open or percutaneously, just like gallbladders are done open or laparoscopically. So I would include percutaneous cardiac procedures done as considered cardiac surgery, done either open or percutaneously.
I mean, I feel like this group of clinical experts, they really carefully considered the definition of cardiac surgery.
Are they physicians and surgeons?
Yes, this is absolutely is the cardiac surgeons, and it is a very long list of codes, especially the ICD-10, and they all got together, even apart from this group, as part of the Maryland Cardiac Surgery Quality Initiative, in terms of the ICD-9 codes, to decide, like, what are our criteria for what's cardiac surgery. There's an incision into the chest, there's cardiac bypass use, there's, a couple of things.
Well, you're defining the old-fashioned open heart surgery.
No, but there were like 4 criteria that they had. Like, I feel like they really thought this through, and what should be counted. Like, I don't feel like this is something where, like, we failed to get the feedback from the cardiac surgeons, or like not enough time was spent on this.
It wasn't a territorial thing?
No, I don't feel like it was anything about I mean, someone brought that issue a little bit in terms of the percutaneous procedures, or right, what's done by the interventionalist, the cardiac surgeon, what the role is. There are these hybrid procedures that involve both of them, but I feel like I really pressed them to think about it.
I think we have really given this a very, very extensive set of questions and interrogations. First of all, I want to thank you, Ms. Fleck, for really an outstanding job in pulling all this together and working with the members of the medical profession, specifically the cardiologists. You've had a lot of feedback here from the commission this afternoon, from Commissioner O'Grady on the whole question of cost effectiveness and efficiency. And I think I know that you will take all this into consideration in the next variation of your effort here. But these are important considerations. There is a very high degree of technical precision that is required in all of this, and I think some of our commissioners have really, because this is their field, this is what they know, have been very helpful in this area. But for example, the point about the economic efficiency, I think certainly that is something that should be included as a change in the draft. Commissioner Thomas raised the whole issue of disparities. I am certainly not an expert in this area. You're talking about two different, databases. You're talking about the Maryland database, the national database. I would include within, the next variation or the next iteration of this regulatory draft some reference to exactly how that will be examined. There must be a way to do it. I would ask you to look at that. I think the classification issues that both Dr. O'Connor and Dr. Pollack raised are important, and we can work through those. I'm sure you can. But in any event, I want to thank you very much for the excellent work you've done, specifically the work you've done in working with the cardiologists and trying to make sure that we do whatever we are doing is going to advance the interest of patient care in the medical profession. Our job is not to set standards for the medical profession. Our job is basically to have them set standards for us in terms of carrying out our responsibilities to the citizens of Maryland. So thank you very much.
Thank you.
The next item is another area where there's a high degree of innovation. Telehealth grant pilot programs. We have been studying the impact of telehealth for quite some time. Angela Abbott, Division Chief of the Health Information Exchange, our division, will present on the 2015 and 2016 telehealth grants. Since 2014, the Commission has awarded over $550,000 in grants to 12 provider organizations to demonstrate the impact of telehealth. Most of the grantees have maintained their existing telehealth projects. Some have been implemented others. The telehealth grant projects have been helped us to inform us in the implementation, our efforts in implementing or expanding the options in the state. Joining Angela at the table is David Sharp, who's Director of the Center for Health Information Technology. Dr. Herman Barreto, do I have that? Barreto, okay, very good. Thank you. Senior Vice President, Medical Affairs, Chief Medical Officer, University of Maryland, Upper Chesapeake Health, as a grant recipient. Is that correct, I think? And I would like to acknowledge the representatives from Lorien Health Services who are here. Lou Grimmel, Chief Executive Officer, Wayne Braddock. Wayne, is he here? Chief Operating Officer, and Jim Hummer, Vice President of Home and Community-Based Services. Ms. Abbott, it's your program, so tell us about how we did.
Thank you so much. I believe that David has a few more names.
Okay, so, and I also have a couple opening remarks to kick things off. Shira Dotson, a grant recipient who's in the room.
Welcome.
We also have Joyce Offer, who's in the room as well. thank you for joining us. And
Associated Black Charities.
yes, the Associated Black Charities. So thank you all for joining us. Mr. Chairman, to kick things off, I would like to let the commission know that staff is excited to be before you today to present on the telehealth grant. There's a lot of work that went into this by the grantees and by staff, and a few opening remarks might bring to light and some context for what you'll hear from Angela and Dr. Beretta as the presentation continues. We're going to talk a little, or they're going to talk a little bit about the benefits and challenges of telehealth adoption. They'll point out some similarities and dissimilarities in learning lessons that occurred from the project that can be used to help benefit other emerging projects. We're going to talk a little bit as a group about the effectiveness of using telehealth, which requires much more than installing a camera and an audio device on the distance site and at the treating site. And we're going to talk a little bit about the successes of some projects and the not so successes of some projects, but yet the learning lessons that were invaluable from projects that didn't fare equally in the success category. And also want to point out that there is increasing interest in telehealth as in the provider-based community. And particularly what we see is telehealth advancing more in the hospital setting across service lines. And our colleague, Nikki Majeski, is going to talk in the next presentation a little bit more about that. But it is also noteworthy that we anticipate slow adoption in the growth of episodes in which telehealth is used over the next several years. Diffusing the technology and saying you had it is very much unlike saying we had the technology and it's being used iteratively on a routine basis. So some of the things we'll talk a little bit more about during the presentation, but I wanted to tee that up to get things started. So thank you all for allowing us to present today on this. Angela.
Great. So I'll begin with talking about our recently ended telehealth grants. These concluded at the end of the year 2017. We awarded 5 organizations telehealth grants. The first set was implemented from December 2015 to May 2017. These telehealth grants aim to improve the health of the population being served and the patient experience. These included Associated Black Charities, Gerald Family Care, and Union Hospital of Cecil County. The second set of grants were implemented in June 2016 to December 2017 and assessed the impact of telehealth on primary care medical home model to meet the needs of different communities. This is with MedPeace and Gilchrist Greater Living. I'd like to take a moment to highlight the projects of these grantees to give you a bit of a flavor of what they uniquely implemented. Associated Black Charities operated in Dorchester and Carroll County. They're a community association assisting minority and rural communities with navigating healthcare systems. They use mobile tablets with community health workers to facilitate primary care and behavioral health video consultations with nurse providers from Top Tank Community Health, which is an F2HC. Gerald Family Care operated in Prince George's County, and there are patients in a medical home that implemented telehealth video consultations between patients in 3 of their family practice locations with Dimensions Health Systems are now University of Maryland Capital Region Health with their specialists, for example, with the gastroenterologist and behavioral health services to provide that access. Union Hospital of Cecil County, obviously operating in Cecil County, built upon their original grant and provided chronic care patients with mobile tablets and peripheral devices to capture blood pressure, pulse, and weight to facilitate patient monitoring. It supported data sharing with the team for chronic care management. And MedPeace is a family medicine practice that uses mobile device applications with their patients to facilitate 24/7 video-based telemedicine with their MedPeace providers to make appointments and access electronic health records. The goal is to increase patient access to primary care for specifically diabetic patients. And then Gilchrist Greater Living, in partnership with Lorien, also focused on comprehensive primary care geriatric medical, comprehensive primary care geriatric medical practice that provided senior patients with in-home telehealth monitoring devices to support case management and early intervention for their chronically ill patients. I do want to recognize, I believe, Leanne Hoover is here, that is with Joe Crest. So take a step back in terms of our grants. We've been issuing grants since 2014, and as the chair said, a significant amount of money has been put forth to about 12 organizations. Our grants really help to inform better practices. A lot of our grants are building their policies and procedures and protocols, and they're able to share that with their peers. Industry implementation and expansion efforts. A lot of our grants are able to sort of inform other organizations looking to implement similar projects, and policies that can support advancement of telehealth, as well as the design and implementation of activities across the state. The grants also help to advance a strong, flexible health information technology ecosystem that's really a foundation for advanced care delivery. So you received our compilation. The compilation includes abstracts of each project, followed by further details of each grantee's final report. The grantee accomplishments really serve as beacons to guide the other telehealth initiatives in general. The promise of telehealth to address problems in care delivery, including limited access to care and even quality of care and cost, is evident in these grantee reports. However, I will say results may vary, sort of like some of those commercials, because generalizing the findings to other telehealth initiatives is a bit limited just because of the uniqueness of the patients they serve and the practices that it was implemented. So I'd like to highlight some common themes that we've seen across all grantees. The one poignant one was that patient and caregivers are really satisfied by the ability to more quickly access or efficiently access their providers, either in the primary care center practice with a specialist, or even within their home with a care coordinator. Also, implementing the technology and incorporating into the workflows was more difficult than anticipated. If you're dealing with two different site locations, there might be two different EHRs that must be used, and there might be double documentation between both providers on both sides. Also, there's limits in terms of the interface between a technology system and an electronic health record. So sometimes that information is not flowed between maybe the vitals that are captured through remote patient monitoring device into an EHR. We saw that within our Union Hospital Cecil County remote patient monitoring project. And they're working on ways to advance that and ensure that integration will happen. Also, practice management systems don't necessarily always communicate with the telehealth system, so the scheduling can be a bit of a difficulty. Provider, patient, and caregiver enthusiasm for telehealth did not necessarily translate to willingness to meaningfully engage in telehealth services. So what we mean by that is all of our grantees were definitely enthusiastic about implementing telehealth, but I think what sometimes happens is once you get into the details and the nitty-gritty of it, sometimes their enthusiasm might wane a little bit. And we saw that in some of our grants. Key to sort of preventing this is to ensure that we have providers and leadership champions within a project in order to ensure that enthusiasm continues. And then grantees tend to underestimate the difficulty in securing funding to sustain and expand their projects. We'll talk a little bit more about sustainability. But one of the things that we're seeing is that some of the smaller non-for-profits or organizations, and even the large organizations, need to demonstrate the value of these projects in order to then justify the cost of spending in addition to expanding those projects. And sometimes that can be a bit difficult for some. So in terms of key lessons learned, so one thing that we continue to see is that successful telehealth requires practices to assess the need for telehealth, really identify the appropriate modality, and ensure sufficient patient provider willingness, and also address the policy and legal compliance issues. We want to make sure that practices really understand whether or not they're ready to implement technology and are considering all the different components that must be in place before they move forward. Telehealth is generally an effective care delivery method where providers from a multidisciplinary approach can provide care. We saw this through our Gilcrest project, where through telehealth they were able to easily incorporate consulting pharmacists into the care of the remote patient monitoring, and then also specifically with ABC or Associated Black Charities, where community health workers were leveraged as trusted community members to really engage patients in their care and encourage the use of preventative services to help efficiently manage chronic conditions. Telehealth provided a way to support and enhance community health workers' efforts by bringing virtual clinical consultations to where the patients are located. Also, telehealth reduced barriers to care in hard-to-reach patients. We saw that specifically within GFC, where they found higher rates of demand for behavioral health services via telehealth among its patients than expected. And offering behavioral health services via telehealth, GFC was able to increase access to these services and counteract the social stigma attached to seeking behavioral health care in that community. And also, Gilcrest was able to really engage elderly patients with technology, where they actually enjoy using technology within the home on a daily basis. In terms of project sustainability, most of our grantees are using operating budget funds to sustain their telehealth projects due to some limitations and third-party payer reimbursement. We also found that ensuring financial viability in telehealth projects really needs to go hand in hand with sustainability planning as well as implementation planning. So as our practices are developing their implementation plan, it should think through how they plan to sustain their project. For example, really understanding how they'll measure the impact and outcomes of the telehealth project in order to justify continuing or expanding their project. And also, as I mentioned, small community-based organizations, while very valuable partners in using telehealth to enhance care delivery, are better partners with large organizations to develop projects to ensure access to operational, technical, and financial support to sustain their programs. So that concludes my overview of the highlights of our recently ended telehealth project. I'd like to briefly touch on some of our current telehealth initiatives that we're working on. The first two I believe mentioned before the commission are two additional telehealth grants that will be launched this coming spring. The first having to do with medication management and reconciliation. We'll hope to fund a project that would utilize telehealth to support healthcare providers to allow pharmacists to provide accurate medication lists, consolidated or reconciled medication lists to the care team. We believe that health information exchange is a key component of this. So we'll be leveraging CRIS to support that sharing of a reconciled medication list through the HIE. And we hope to award the grant next month. The other is our medication-assisted therapy, or MAT, for opioid use disorders grant. We hope to expand access to MAT with buprenorphine for underserved areas of Maryland with residents that have opioid dependence. The aim is to ensure that patients who need the appropriate treatment have access to that treatment, even in, say, the rural areas. This will be awarded hopefully late April or early May. And then finally, we were working on a telehealth readiness assessment tool. What we learned, as David mentioned earlier, is that simply implementing telehealth doesn't mean it will be embraced in care delivery. We want to ensure practices understand where they might have gaps in their knowledge or readiness for telehealth. So we're contracting with a vendor to establish the readiness assessment tool, developing questions and a scoring methodology that will allow for providers to use the self-assessment tool to gauge in certain areas where they might need to shore up their ability. So finally, I'd like to highlight some of the grants that were awarded early in our implementation of telehealth grants. These concluded in 2015 or 2016. There were 6 organizations that implemented projects to either one, facilitate the transition between acute care hospitals and nursing homes, or 2, around remote patient monitoring. In reaching out to these grantees, we understand that 2 have sustained their existing projects after the grant period had ended, but also all grantees have implemented other or adjustments to the telehealth project, building off of the work and the lessons learned from MHCC-funded grants. We've invested a total of $157,000, where a match was provided by the grantees, and about $393,000. So we have one of our grantees that was part of the initial project with University of Maryland Upper Chesapeake. I would like to say a few remarks.
Doctor?
Good afternoon, everybody. My name is Dr. Samin Barreto, CMO for University of Maryland Upper Chesapeake Health, and myself and our VP of Population Health, Colin Ward, partnered with Lorien and Lou Grimmel with a telehealth project that connected their skilled nursing facility. Initially, it was one, Lorien Bel Air, with our emergency department back in the day when I was a chairman of the emergency department. Telemedicine definitely interested me, and we were able to take hold of that project, and we had some tremendous success during the grant period, where we saw a 38% reduction in readmissions, and started to realize some interesting benefits that weren't necessarily mentioned in the presentation. And I'm going to go through just some of those unique pieces. Providers, those that are innovative and like this type of communication, really gravitated towards it. Patients definitely enjoyed the opportunity to see the provider quickly and actually get to stay within their residence. The other benefit that I have now realized 2 times, because our program now is a couple years old, is we've gone through 2 flu seasons, this one being one of the worst ones that we've seen in a decade. The benefit from an infection control, infection prevention, of being able to maintain that patient there, treat them there when they have comorbidities in the elderly, to prevent them from coming into the hospital, I think is something that can't be ignored as far as an additional benefit, and really needs to be pointed out there. We had an array of patients that we were able to keep from coming to the hospital and cared for them in a safe and high quality fashion. Everything from congestive heart failure, post-op CABG patients who had just received simply too much Lasix. Potassium had gone up high. Probably an emergency physician seeing that patient would have admitted that patient quite quickly, assuming that the post-acute, that the skilled nursing facility wouldn't be able to necessarily handle it. The added benefit here, and that actually reminds me, was actually educating our providers on what they are able to do at these skilled nursing facilities, and their capabilities have increased, I think, tremendously in just the 10 years that I've been up at Upper Chesapeake. That knowledge and education, I think, has been invaluable in improving our collaboration and ability to care for these patients between these 2 facilities. So, and the types of other, quickly, just 2 other types of patients that we did cover. Your metabolic disorders, hypoglycemia, being able to identify on an EKG abnormalities, I think was extraordinary. Probably the technology that held us back some was the stethoscope, and I've been asking around. Anybody got a good idea on it? Please let me know. The can and the string probably is, almost as effective sometimes. We did move to a new technology that I think may solve, or at least partially solve, this problem. Their ability to do laboratory testing and radiology over there at Lorien, I think really helped. But more services you were able to pile on versus just a good old-fashioned FaceTime or Zoom connection, the broader the scope of the patients you are able to maintain. The reason we were able to sustain our program, we immediately saw the value and the decrease in readmissions. Right now, I believe we are number 6 in the state with regards to our readmission rate, with the 5 other hospitals being either quite small, 20, 40 beds, and this is in no small part due to our continued expansion now into all of the Lorien facilities. Took on Lorien Riverside, which is a much larger facility, and they have caught me at every hour of the day now. And I found out that my 4-year-old daughter knows how to open my door to my telemedicine room in my home. So that was one small error. That was my lessons learned: the lock door and then bar it so that your kids can't come in. So it has been an evolution. We've been able to make the case based on our pay for performance, metrics through the HSCRC. But that is a challenge in trying and push that forward. This is essentially self-funded at this time, where we pay the providers through the Chesapeake Health monies. The further expansion, which I think really is a specific effect from this grant, is we have now expanded telemedicine between our 2 facilities with a tele-infectious disease consultation service, and we're even looking, I think we're going to implement just in this next week, the remote monitoring program for our post-discharge patients. So you can see how we've grown now just from what was a connection from one facility to another. We are now expanded to, and hope to expand to, all the skilled nursing facilities. But Lorien has been our partner, and we've been able to connect with all of them now. And now connecting our 2 Hartford Memorial and Upper Chesapeake sites, and now connecting directly with patients from our comprehensive care center. So the expansion has been, I would say, quite rapid, and we're looking forward to more innovations, improvements in technology. I think one of the barriers that I think is improving over time is the payer situation, but I guess that remains to be seen. I never hold my breath too much on that one as far as it happening quickly. Anybody have any questions about the program?
Commissioner Thomas.
So I was just at an Academy of Science meeting yesterday on health literacy and the elderly, and this telehealth came up, okay? And I think there's some real value in more, it's going to sound strange, more failure, more examples of what doesn't work. Because what came out of that meeting was all this high enthusiasm and then the reality. And what happens is that people can overhype or oversell, think it's a panacea, but the reality is far different. I think Maryland can really help in showing where the pitfalls are, how we overcame them, a culture of kind of like the airlines. When they make mistakes, they go in, they deconstruct it. It's not a bad thing. It's a good thing. I think we need more of that here. So one of the issues that came up with the many elderly, we're talking 65 and over, have real problems with the computer versus the human. I'm assuming yours is all computers and not these, right?
Correct. No, we had workstations.
Okay. So you give every patient a workstation at their home?
So the skilled nursing facility had a telemedicine room. They would connect with our workstation at the hospital. As far as the remote monitoring, that's a different program.
Okay.
But we do Skype call and Zoom with them in our comprehensive care center.
The device used by Lorian at home for remote patient monitoring is a stagnant or workstation where the patient is able to take their vitals easily, and it gives them extra information besides just the health stuff.
Yeah.
Things that are more of interest to that individual, family photos or whatever.
Yeah.
So I think the extent to which we drill down into some case studies with examples. So you mentioned some of the challenges, but now really, put a face on it, illustrate actually how it happened, how it came about, how you rectify. That's what's missing in the broader discussion that Maryland's initiative can add value to. A culture where errors, mistakes, failures are a good thing, because this is complicated stuff. Mm-hmm. And I would also say that on the sustainability, it might be more expensive. If it really is quality, if it does better patient outcomes, it could be more expensive. So we don't necessarily want to make the case totally on how much money we saved, because at the end of the day, it has to be about what's best for the patient. And the last thing I'll say, it has to do with attribution. And it's just a caution, because so much happens once you put these things in place. How are you really confident that the outcome is directly related to what you did? We don't have control groups. We don't have randomization. And so with the limitations of the design, I would just simply say, how do we caution or attenuate any of the attribution that this is what made it happen?
So I can answer that on a couple of different levels. First, I think the reason we've taken telemedicine and that innovation as aggressively as we have is because we do believe it expands the scope of healthcare and allows us to be able to improve the health of more patients. So that has been our North Star. We definitely didn't go into it thinking we were going to save and pay for it. We had our eyes wide open with regards to that. With regards to attribution, we looked at the data both at the skilled nursing facility at Lorian, and it was a basic before and after type performance where we saw that 38% reduction, and that was sustained. Now, for the tele-infectious disease, actually, we were able to be a little more scientific about it. We actually took both previous month's performance. We also took the same month from the previous calendar year performance, applied some basic quality metrics of days of therapy on antibiotics, readmissions, mortality, and length of stay, as well as controlled for CMI. And we're actually looking towards publishing this data in a more scientific and rigorous format. And it's essentially a no-harm study. And about the only metric that did fall off, I don't believe it's going to reach statistical significance, but it's still there, is the readmission data. Then we did do some patient experience surveying, and there were some that did not appreciate it, which you would partially expect, and it was the impersonality that you would expect with looking and trying to talk to a TV instead of a person. So to the best that we were able to look at with the data that we had, in that particular instance, we felt like we were able to expand services and maintain quality of care in this patient population. With regards to the skilled nursing facility, each facility we've gone into, we've seen a subsequent reduction of readmissions. So, after a while, it stops being an accident.
Yes, Dr. Pollack.
I mean, that's a great report. Thanks very much. Can you talk a little bit more about the readmissions and the financial impact through the readmission reduction incentive program?
Sure, I can.
And the size of that relative to the size of the investment in this thing, because I think it's an important fact. It's an important component of understanding the sustainability of these programs.
True, I believe Thomas actually said it well. It's not going to pay for itself. If you take a general estimation that a readmission costs you on the pay for performance program about, there's been estimations between $10,000 and $14,000. A prevention of one of those readmissions, of course, would help pay for this program. I believe our total, then you've got startup costs and then monthly maintenance costs. I would venture to say that we're probably still coming out in the negative as far as the total cost with the readmissions, but there's other things that are also involved here that I wouldn't even be able to include into a business plan, if you will. The number of readmissions we were able to avoid in just the first few months of the telehealth grant, as far as a raw number from an 85-bed facility, I believe, was on the order of about 10 to 12, which would have paid for a lot of, what we were talking about. So, these are rough numbers and small sample size. It will be more robust as we get more data, more facilities, and more patients. And we'll be happy to try and share that data and see how we come up with it. At some point in time, we really do need to take a look at that analysis of how these patients did how we did in these facilities over time, the admission reduction, and how does that directly impact our, readmission program. That specific analysis has not been done. So we don't have to start looking at that now that we've got some better numbers.
Any further questions? Commissioner Sargent.
Did I hear you right? You said the stethoscope was one of the hardest?
Yeah, well, because the seal on there has to be quite good. The connection and the Wi-Fi has to be very strong to prevent any static. When you're trying to listen, even when I'm doing, you're doing it on a patient yourself, if you're trying to do it through clothes, you hear, well, imagine that magnified times 10. It's like this, this microphone. It's not very, it can be very challenging sometimes. So the stethoscope was probably the one we were hoping worked the best, and we had some challenges. It continues to get better, and I suspect, like all of these things, eventually it'll be as good as, my iPhone in my pocket right now, but it's not there yet. Sure.
I have a question. One of the top issues about project sustainability is third-party payment, third-party reimbursement. A simple question, but does Medicaid, for example, reimburse right now in Maryland for telehealth?
So
Medicaid.
Medicaid. You're able to answer that one better than me. I know there's.
So Medicaid does reimburse for telemedicine. There are some restrictions in terms of the eligible types of providers that can be reimbursed. And they also require Medicaid providers to register as telehealth providers before they can actually get reimbursed.
Does that create any kind of barrier as far as you know?
So anecdotally, we've heard that for some it is a bit difficult. I would say that Medicaid has made improvements in terms of the registration process. They have an online form. Before it wasn't online. They streamlined it a bit, but there are still some providers that don't qualify for telehealth services. Although Medicaid is also looking at expanding provider types and recently released rules around remote patient monitoring reimbursement under circumstances.
So would it be fair to say, with regard to the Medicaid program, we're looking at progress with regard to expansion of reimbursement? Okay. I should know this, but I don't. Does Medicare reimburse right now for telemedicine?
So Medicare does reimburse. However, it's restricted to certain areas that are underserved in rural areas, which Maryland doesn't have too many of. And they only reimburse certain codes or services as well.
So, as an example, we did our tele-ID consult, and we actually submitted to all payers, and our denial rate was 72%. So
72%?
Yes. So 28% of charges were recouped as a private ID group. They submitted denials to us, and then we reimbursed and made them whole.
To me, here again on the case study side, the whole continuum, that's a really, really important story. So did they just say no? Did they say why they said no?
I have, because they're a private group, I have asked if they wouldn't mind if we partnered with their billing company to get a deeper dive and understand the reasons for denial. But they gave us very polite no's twice for the second denials, and once they had gotten to that point, we said we would make them whole, and that was the agreement we had going into it, expecting a high denial rate. I don't know if I was surprised or not by this denial rate, but I'm happy to share that data once we actually get it. As you can imagine, it's not easy to get, so we're working diligently with them and hoping to learn as much as we can from this experiment. It was actually an experiment done because of short staffing. We had lost an ID provider. We only had 2 to service our 2 hospitals. So in order to maintain quality again, we were able to expand and keep people more efficient by keeping them at Upper Chesapeake and remoting into Hartford Memorial. So it was an effective experiment.
Well, one thing, Doctor, about being involved in health policy is you learn something new and exciting every day. So thank you for that revelation. I think Dr. Thomas and I are going to have some conversations, as they say.
Mr. Chairman, to build on your last point, I would say to you that what we do with each grant that we develop, we take the lessons learned and the experiences from the grantees, and we factor that in as we test the next sort of project as we strive to making this as a seamless technology diffusion as possible. And we are making great strides in having that occur. So I think that's important to note that we build on what we learn. And the one point that Commissioner Thomas made, that we are very sensitive to is that failures are good things, although we don't like to say that because it doesn't sound very positive.
The public relations is always tough on that one.
But what we do when things fail is we go in and we work with grantees to figure out why. And we do this incrementally. We don't wait until the end of a project. We figure it out, we determine what the causes were, and we use that as a learning lesson to build upon. And some instances we're able to help the grantees sort of redirect and to something better. And in other cases, we have to step back and say that just didn't work and let's move on.
It's your view, Dr. Sharp, that we're basically going in the right direction here with regard to the promotion of telehealth. I mean, for the purposes of Maryland and the role of the commission and public policy, we should put our foot on the accelerator on this. Is that your view, basically?
Mr. Chairman, as a matter of opinion, I would say absolutely without a doubt. In my nearly 20 years at the commission, I feel that this technology revolution is happening much more easily, and none of it's been easy. But in comparison to complexity, then whether it was implementing electronic data interchange, whether it was EHR adoption or health information exchange, we see direct impact on patients and consumers and caregivers. So it feels very good, and we have a lot to be appreciative of in the leadership here and the work that's occurring.
I guess you've seen Secretary Azar has made a rather dramatic address, talking about a number of initiatives which are very compatible with the kinds of concerns that we've adopted here at the Healthcare Commission, specifically the emphasis on price transparency. But the other point is trying to basically expand effectively the use of electronic information, health records, and specifically interoperability. And frankly, I think it's something that we may want to consider offline at some point. But how the commission, how Maryland can better interact with the administration on taking advantage of their initiative. I don't think they're interested in disrupting anything we're doing. The question is, how much would they be willing to help us very directly? And likewise, as you had indicated to me earlier, there's interest in the administration in talking to us about some of the progress and success we've had.
That's correct.
So anyway, are there any other questions? Yes.
Just very briefly,
Thomas?
something David said, I don't want to get lost. You know, as a kind of providing the oversight with the attitude that you have regarding failures means that the actual implementers don't have to fear sharing with you what is actually happening on the ground. That's a culture change. You have to understand that's not automatic. So that should also be part of our case study. When you encounter those things and you're interacting with that should be part of the narrative. That's a missing kind of a black hole in understanding how these things are actually working. So that when you actually do get something successful, we're not able to disseminate it and scale it up because no one's talked about all the hurdles along the way. So the very way in which you're doing the oversight is also part of the success. So let's not lose that and figure out how to get that incorporated into the overall narrative.
Commissioner O'Grady?
Just one brief kind of context and sort of lesson learned here as well. One of the sad parts of this story is that telehealth, when it first came out 10, 12 years ago, was pretty shaky. I mean, wouldn't call it fraud, but there was a lot of, let's say, bad actors, and it set this tone. And so, when you said that sort of rejection rate and that there's sort of this built-in skepticism, it's not like it came out of thin air. Guys just, mailing people VCRs and saying, $100 please, this kind of stuff. And so that is but when we think about this the more general process, we have something we think is innovative. How do you want to move it to market? How do you want to scale it up? Those first few steps are fairly important because of the long memory that people have about, home health is still living with, kind of the nature of abuses from a decade or more ago. Oncologist billing still, gets an extra look because of their abuses of the past. And so this is sort of when we think about whatever the next equivalent is going to be, how we get it started, how we get it off the ground. It's pretty important that you learn your lessons from your failures. At the same time, be sure you're really ready to go. Be sure you get off on the right foot. Otherwise, you're going to have this constant skepticism factor built into the system that will take you decades to overcome.
Commissioner Sargent?
Can I just ask one question with the SNF and the hospital, the doctors at the hospital? Do you know how that was billed? Did each submit a separate claim?
We didn't bill for, we connected the emergency physicians with the skilled nursing facilities, and the hospital paid per consult.
Okay, so there wasn't a claim.
There was never a claim made. And then we actually afterwards had our risk assessment just to make sure that we were abiding by all compliance and regulatory standards. So we still, although we were, abiding by every letter of the law, we were not submitting any claims.
Are there any further questions from the commission? Angela, gentlemen, thank you very much for an excellent presentation. Thank you. Commissioners, the next item on the agenda is a cousin of what we've just talked about, hospital health IT. We have a report on key findings from Nikki Majewski, Division Chief, Health Information Technology. This is based on an assessment of Maryland acute care hospitals. The report highlights key trends and challenges and strategic health IT initiatives that are underway in support of improving quality in healthcare. The findings are used by stakeholders to inform policy discussions and the best practices to advance statewide health IT. Nikki, thank you very much for showing up and fill us in.
Thank you. Good afternoon, Commissioners, Mr. Chairman. So to just build on what you said today, I'm going to present to you some of the key findings from our assessment that highlight some key trends, challenges, and the strategic initiatives hospitals have underway using health IT. just to kind of highlight some of the key takeaways here, hospital health IT strategies are aimed mostly at maximizing population health management. This requires advanced use of data analytics to improve clinical decision making and reduce costs. But more work is needed here to kind of advance how they're using patient data to kind of gain a more prospective look of risk among their patient populations. While telehealth is expanding, as we just heard, hospitals are at different stages of implementation, and sustainability can remain challenging. In terms of patient portals, federal meaningful use requirements have not fulfilled the intent of engaging patients. The industry has basically taken a step back to reassess, and over the next year, we can kind of expect some federal policy guidance with the push towards more consumerism. And lastly, Maryland hospitals do exceed the nation in cybersecurity risk mitigation techniques. However, with the increased reliance of network technology and the proliferation of these emerging threats, comes greater need to enhance security. Just a bit of background here, with HITECH being the unique federal policy that has spurred a lot of change in hospitals over the last 10 years. Maryland hospitals have received over $300 million of roughly $27 billion that was allocated by the federal government for meaningful use. Before HITECH in 2008, about 16% of Maryland hospitals had adopted a basic EHR, compared to about 9% of hospitals across the nation. Today, all hospitals have a certified EHR, 96% nationally, and all have demonstrated meaningful use. Moving into the key findings here. With alternative payment models advancing and placing more emphasis on care transformation, hospitals identify their top 3 strategic priorities as being advancing population health management, increasing quality and efficiencies, and advancing telehealth and mobile health initiatives. Hospital telehealth projects, as we kind of learned here, augment their population health activities by expanding access to care, creating efficiencies, and aiming to reduce admissions and monitoring at-risk patients. Alternative payment models are also driving hospitals to strengthen alignment with physicians and enhance collaborations with other care settings. And determining how to engage patients effectively remains essential to achieving population health goals. And it's not necessarily a lack of interest by hospitals, as we see here. It's not necessarily a top strategic priority, but it's very dependent on an interoperable health IT infrastructure, which we'll get into a little bit later on. So for data analytics, most hospitals have data analytic capabilities, which is about a 20% increase from last year. Hospitals in general have done a great job with clinical analytics, but as I mentioned, predictive analytics will drive more improvements in quality and key to improving clinical decision support. Hospitals report some challenges in advancing their data analytics, which is due to competing priorities, limited analytical tools and computing infrastructure, and insufficient financial resources. With telehealth, hospitals are generally at the forefront of this compared to other provider types, with 88% reporting one or more telehealth projects. This exceeds the nation about 17%. As telehealth gains traction, they kind of are struggling somewhat to deploy these programs outside of a hospital setting, and funding remains kind of this ongoing challenge. Hospitals do report, though, improving quality and reducing readmissions are the key drivers of telehealth. Then increasing efficiencies and expanding access to care ranks 3rd and 4th and aligns with top organization goals reported by healthcare organizations nationally. As mentioned earlier, a lot of hospitals, it's important to note, are in various stages of implementation. About half are in kind of preliminary stages, and 40% are kind of in an optimization phase where telehealth technology is fully functional and they're, rendering services actively. There are barriers hospitals do report to expanding telehealth, which includes the maintenance costs, lack of reimbursement, and the limitations in technical infrastructure. To kind of address the point I made earlier around patient engagement, here we see a clear illustration where widespread implementation of patient portals, yet few patients use the technology. The Medicare incentive programs and Meaningful Use Stage 3, which began this year, aims to increase consumer access to their health information through centralization. And this requirement basically encourages technology vendors to develop cloud-based PHR solutions, a personal health record, to allow consumers to obtain their information from one website. Given this portal overload, especially for patients with chronic conditions who might go to more than one provider. We asked hospitals about how many kind of have make available to vendors electronic information that's consented by patients, and 31% do. And around a little over 60% indicated plans to do this over the next 2 years. Hospitals do become increasingly dependent on ASIE to advance care delivery and inform population health. As utility of CRISP advances from query-based exchange to care alerts and analytical services, some hospital-owned ASIEs have ceased operations in the last 2 years to avoid in part duplication of services. Technical requirements here pose steep challenges to making electronic health information available within the provider workflow. And we generally can see, say for the most part, ASIEs slowly moving towards EHR vendor-driven exchange, where ASIEs provide more record locator services, secure messaging, and analytical services. Lastly, moving on to cybersecurity, hospitals largely agree that email is their greatest vulnerability, and this is consistent with the nation, and attribute it to the phishing scams that attempt to exploit vulnerabilities in the end users. And we've seen this with the breach data, where in 2017, almost half were attributed to the hacking IT incident, citing email and network servers as the primary location. Interestingly, perceived risk of mobile devices ranks lower than hospitals nationally. In general, though, Maryland leads the nation in deploying techniques to investigate cyber incidents. Monitoring networks and system activity logs are most common, and hospitals leverage cyber threat intelligence almost twofold compared to the nation. The proliferation of emerging threats ranks foremost in Maryland in the minds of hospitals as the leading challenge to mitigate risk. And this is kind of a bigger challenge as more medical devices are linked to legacy systems, potentially creating more open doors. Looking ahead, we can, as mentioned, expect advanced use of data analytics to allow hospitals to benefit more from cost containment and support care transformation, devote more resources to their IT infrastructure to secure systems, medical devices, and protect patient data. Further expansion of telehealth services to engage and manage vulnerable populations, and enhancing consumer engagement strategies consistent with national priorities to give consumers more access and control to their data. That concludes my presentation. If you have any questions, I'm happy to answer them.
Commissioner Thomas?
Always fascinating. You know what's interesting to me? When these things work and we reduce readmissions and we do all these things, I can't figure out why, whatever the costs that were avoided, aren't rebudgeted to support whatever we're saying made it happen. In this case, telehealth. Or, you know, your part. Same thing with David. We heard the person say, we reduced hospital readmissions, and he put a number on that. But I'm trying to figure out why we still struggle. Are those real numbers or just moving numbers around on a spreadsheet? Why aren't those re-budgeted to support these efforts? It's a rhetorical question. You may not have an answer, but you might. Because it comes up every time. They don't know how to sustain the program after the grant money goes away. I don't understand that. when they say there are things that are working and saving money, but none of the savings seem to be rebudgeted.
So I think, as Angela had mentioned early on, I think sometimes there's this lack of planning for sustainability needing to be parallel with their implementation. They got the funding and they go, and then they get into it, and it's one of these things they're further assessing as they kind of build upon these lessons learned. I mean, I think there's more effort to kind of expand on that.
Commissioner Pollak.
Yeah, I think, yes, it's a phenomenal question, and it requires an understanding of the GBR model. So the GBR model includes increases in funding each year that are inadequate to meet basic inflationary needs. So any savings that you get are savings that were absolutely projected to be had in the context of an existing cost structure. So any cost that you add to the program to achieve those savings is cost that gets added to the basic cost structure. It's not enough. You can't generate just enough to cover the cost of the program. You have to generate the cost of the program plus the cost of the infrastructure plus the cost of the unfunded inflation that's in the GBR. So it's a flaw in the GBR model, and it's basically the idea that somehow you can underfund inflation and expect the innovative programs to make up the difference is not, that math doesn't work.
We have to increase our funding for inflation.
Just an observation. Our facilities never participated in telehealth. I saw when the grants started to come through. We're just a small company. Just a couple observations. I can see where the hospitals are very interested in that, as Commissioner Pollak saying, as far as our colleague here when they presented with avoiding readmissions because we get dinged for it, and it does save money. I know the federal model for reimbursement for long-term care may change as well, where we get dinged for hospital readmissions. You may see more facilities or companies wanting to utilize such technology. Lorian's a larger company. I can see why maybe they took on that task at first because they can afford some of the cost that was involved with that. Back to Commissioner Thomas's observations. For a company like mine, it would have been a significant risk maybe. And to go forward, then after grant funding had sunsetted, might be a challenge as well. One of the other things, and I know they spoke to as far as the education component with, I live in a rural area. My company's in a rural area where folks, they don't even like the term hospitalist, let alone somebody, on a monitor. They want to see and touch and communicate with their physician directly. So there's a little bit of that component, a lot of education that may need to go there as well. So I just wanted to mention a couple of things as we talk about telehealth and IT technology, just in that regard. As far as electronic health records and technology, I know that the long-term care community is pretty advanced in that. But the challenge we see with switching gears a little bit, the challenge we see there is there's so many different types of software out there that's being utilized, and making those all talk or communicate is a real challenge. I know in our facilities connecting with CRISP through a grant, that was a real challenge, was to get the communicability of those types of software to talk to one another is a pretty daunting task. And that's one of the things, I've heard me say it here before, that as we, move forward, and I think that, it's inevitable that we'll move forward in health technology in these areas, but that's a big challenge that we'll have to confront, and it won't be uncostly, and it won't be without its, setbacks.
Thank you, Commissioner Metz. Are there any other questions? Yeah, Commissioner O'Grady.
Yeah, it's just an aside to Commissioner Thomas's comment. One of the things that we're trying to do here is have innovative come out from the providers themselves, and that's certainly a very good idea. But the idea that sometimes you see these stumbles of how you get them properly reimbursed, there certainly is a tech. I mean, if you deal with device manufacturers or drug companies, and not, disparagingly, but how they approach the FDA, how do they talk to them first and make sure that they'll have, clinical trials that will have the characteristics they need, so that there's no question when they get to the review. How they talk to insurers, how they make sure, how they line up kind of experts in the field from the medical community, kind of luminary providers to be able to do these things. They're pros at it, and they have the money to do it, but there's a whole field that is sort of reimbursement consultants who will help them, and not in any nefarious way. You're going to need this data. You're going to need the top guys in the field to say they need this new service. And it's a much different story than what you hear there. Is it long? Is it burdensome? Is it expensive for them to do it? But they're out of business if they don't figure out how to get these things reimbursed. It's just then they're really losing money. So there's a whole, but to expect, a nice doc from the Eastern Shore to be able to hold his own in that world is just, and it's, so you can think about, are there different ways we might want to think about things to help people who come up with those more innovative things. But there's a pushback to sort of have the government decide and then impose it on the rest of the country. And so you want it to come up from the grassroots, but there's a big, it's way more than varsity versus JV when it comes to actually navigating the reimbursement process to make sure the insurers reasonably have the data they need to feel comfortable covering something, and not, stories and, little kids coming in and telling a story about, bad things happen to me if I don't get my $200,000 drug. They need something. So you're just seeing a David and Goliath there to a certain degree in terms of who knows how to navigate this system and who doesn't.
Any further questions from the Commissioner? Ms. Majewski, thank you very much once again for a terrific presentation. By the way, I just want to reemphasize a point before we leave here. There's a jewel in the body of your presentation, and it is that, quote, Maryland hospitals lead the nation in deploying techniques to detect and investigate cyber incidents, monitoring networks, system activity logs, and so on. I don't know exactly how much credit we can take for this, but I know that Dr. David Sharp and his team have made this a very big issue over the past couple of years. And I like to think that this commission has had something to do with that. Would it be a fair assessment that we have had something to do with that?
I would hope. I mean, we've taken advantage to kind of facilitate peer-to-peer learning sessions. So, I mean, through greater collaboration, we can only get stronger.
So I think that when this final draft goes to our friends in the state legislature, I think in the cover letter that ought to be mentioned because that is a rather critical improvement. Considering the fact this is becoming, breaches of security are becoming a national phenomenon, we've got to, and we have a right to crow, I think, and we have a right to be proud of the work that we've been doing here. Thank you very much, Nikki. Our next item has to do with the status of legislation.
Yes.
How are we doing, Ben?
So
we're now talking about what's going on behind enemy lines.
Well, time is running short. Before we leave the last presentation, it did occur to me that as our partners in pilots typically include groups of providers, we probably ought to also have a payer partner to the extent we can, when they're able to see the success themselves directly and be part of an initiative. I think it sometimes drives the ownership much more quickly than us presenting a report finding. And probably a criteria for a grant is, do we have a payer partner, maybe not always providing some of their own cash, but at least from the standpoint of participating hand in hand with us going forward. I think this is something we ought to probably consider. The sustainability has been a challenge on a lot of our telehealth initiatives. We have made attempts through the legislature to get ongoing funding, and I think the legislature quite correctly says, well, this is really a reimbursement issue. The payers ought to be stepping up, and engaging them. Some are more active than others, but I think there's now sufficient evidence that we ought to be moving beyond pilots to taking this in areas where we think there's real opportunities for success to a full-scale implementation. Not every area is ripe for that sort of development, but we've done a lot of pilots, and it's time to see if there's things that everyone would like to latch onto. So with that, I'll turn to my presentation. Nikki drew the straw being preceding me, so she's going to flip through the slides. We have 3 weeks left. The crossover date is Monday, meaning bills that have until Monday, if they pass one house, have to cross over to the other house in order to get routine consideration in the other house. So the next couple of days, there's going to be a press in each house for action on bills that originated in that house. And in fact, unlike other years, most of the bills that have passed have not been heard in the opposite house because of the number of bills that have been introduced. In total, about 4,000. This has been a high watermark, if you will. I want to cover basically only about a dozen bills today. We are monitoring a number of others, including the health insurance exchange legislation, but that doesn't really have a direct impact on us. They include, most of these have been brought before you previously. Senate Bill 13, that piece of legislation did not receive favorable action as originally drafted. The sponsor in the House is trying to move that forward as a required study, in which we along with other stakeholders, would look at the feasibility of using the PDMP, the Prescription Drug Monitoring Framework for expanded collection. We have suggested that a letter from the chairs, if they think that's warranted, might be a way to consider to examine this. It remains to be seen whether this is going to see further action. Senate Bill 17 is actually something we own, and it expands the definition of health information exchanges. What we have said is to put entities that behave like health information exchanges under the same state regulatory framework. That has passed out of the Senate and is scheduled for a hearing in the House next week. We think that's very possible that that's going to pass. Senate Bill 266, which we cross-filed as House Bill 716, has passed. Each of those bills have passed the respective houses and will cross over. The Senate bill will be heard in the House next week. As you may recall, we asked an amendment be added to give us some additional time. The Senate Bill 234, that has had hearings. It looks like that's going to have some tough challenges ahead of it. The Board of Physicians has offered a number of maybe I should say difficult amendments. Clearly, the idea of interstate medical licensure is one that this commission has supported. There are some challenges with this particular bill, and we'll assume that the legislature will work this out one way or another. It may be pushed to summer study with a more a bill that has broader support next year, particularly from the Board of Physicians. 619 and House Bill 1282, we've got, this is a small bill which removes certain health management organizations from certificate of need requirements, specifically as it relates to the establishment of ambulatory surgical centers, when those centers serve principally the HMO's subscribers and the indigent population. We are literally fighting syllable by syllable for this piece of legislation with the sponsor, and it did finally it passed quickly in the Senate, but it had a number of roadblocks. We think that's been resolved. And it's a small piece of legislation. As I've said a couple times, it does demonstrate the challenges of trying to move forward any revisions to our certificate of need statute because lots of stakeholders weigh in. At the hearing on yesterday, there were lots of questions to me and to the sponsor to see if there was some hidden trick in this bill that everyone was missing. So there's generally, when certificate of need goes at issue, providers and payers do wonder the reason why. And simply taking the word that we believe that regulatory simplification and allowing greater flexibility doesn't often get seen as the only justification. So this is a good dry run for, I think, a more ambitious effort next year. And what I think it does demonstrate is there's going to need to be a lot of legwork with the legislative leadership on the whys and the wherefores if we want to make substantial progress. That said, we are not going to be successful with the other bill, which I think is really important, but will not pass this year, which is on the removal from certificate of need oversight, the high-end drug rehab facilities that is being put in the chairman's drawer in the House. It was not cross-filed. It was probably a tactical error not to have this bill originate in the Senate, where it had a more favorable audience. But since it originated in the House, it's not going to break out. Crossover, as I said, is on Friday or on Monday, and it has little prospect for a vote before then. A couple pieces of legislation that relate to work of the work group, Rural Health 266. Yes, I think 266 is moving forward, and we expect that actually to pass. The identical versions, but under different bills, the Senate and House bill, have both passed, and we've agreed to put resources and funding into that piece of legislation. The Rural Health Work Group, the first bill is one that we support in concept, but it needs work, and that relates to the expanding the definition of services that can be provided by EMS providers in support of what are called mobile integrated health programs. These are EMS run programs in collaboration with other, sometimes the county health officer, sometimes other providers, in which EMS is able to provide some basic types of healthcare services rather than simply providing transport services to patients that dial 911. It's been shown to be very successful in Queen Anne's County, and fledgling pilots have also been started in Prince George's, Montgomery County, Charles County, and Carroll County. We, as we talked with you, we support this concept, but we think there are further definitional issues that need to be considered, including specifically scope of practice for EMS personnel. In other states where this has taken root, they've actually carved out a new provider category called a community paramedicine professional. In Maryland, the bill as drafted is very vague on how this is all going to take place. We will be participating on a work group on Monday in the Senate. It's not a cross-file. Again, read that crossover is Monday. So if you're having a work group on Monday, that should indicate the prospect that it will succeed this year as being pretty low. I think it may be well worth it to spend some additional time in clarifying the scope of practice for EMS professionals, and then putting something a bit more thoughtful in place that has the support of payers and some of the other health occupations that are concerned. Inevitably, when scope of practice changes, other provider categories become concerned, sometimes legitimately, sometimes simply because the new scope will collide with the responsibilities that they deem as their own. The cornerstone of the Rural Health Work Group, the Rural Health Collaborative pilot, is also moving forward. There was a small amendment that recalled that the collaborative focuses on building what are called rural health complexes, an abstract term, intentionally so, that really focused on providing or enabling the establishment of some healthcare services in as many rural communities as possible, with each complex being somewhat defined, the scope of it being defined by the size of that community and the needs of that community, as well as that community's proximity to other healthcare services. It's gotten support in the Senate. It was amended to include within the complex the establishment of acute care services, which does, I think, directly address the issues related to rural hospitals. We'll see how it fares in the House. I think it does make some sense to include the concept of both ambulatory and inpatient services. I know that it's not universally supported, however, so we will provide our letter of support and expect that the House will consider it before it closes. Lastly, a piece of legislation that we have looked at in the past 2 years, related to providing a framework in which community-based oncology could offer what we call, or what are called, integrated community oncology programs. In Maryland, because of the self-referral law, that is not permitted. Oncology, orthopedic practices, urology practices are not permitted to own and deliver services for radiology, both diagnostic and therapeutic imaging. This particular bill would have allowed a framework under which oncology practices could have done that. We made some headway this year, but prior to the session, Senator Middleton, certainly oftentimes a supporter of the Commission's work, but not in this particular case, had sent a letter to HSCRC asking them to study the impact of community-based oncology programs on the all-payer model. That seemed as though it was a roadblock to action in the Senate on this bill. They pointed to the Middleton request as a justification for any action. We'll be working with HSCRC. In fact, they likely will be using our data in their study. We had suggested in the bill that the bill be amended to largely put into the legislation requirement that certain types of advanced payment models, either approved in Maryland by CMS or approved elsewhere in the nation, specifically the oncology care model, also be considered as a basis for deeming a program as consistent with the new all-payer model. I think people sort of like that idea, but there was doubt as to whether CMS would actually agree to that. It put in Maryland law a commitment, but it didn't put in federal law, obviously, a commitment that that would actually happen. So it's been withdrawn by the sponsor. I think more work is going to be completed on this. I don't think we need to. Can I put that in? Sure.
So I guess, you know, and we hit this all the time where you find this sort of, you know, there was some I keep using the term bad actors, some abuse in the past, but now we see that practices are sort of, you know, you see it in imaging and, you know, kind of, you know, we do this all the time. Why am I sending it down the hall? Why don't we just have a CAT scan in our office, be more efficient, et cetera, et cetera? And the reason is because 10 years ago, you guys, you know, ginned up a lot of bills that were, you know, of unneeded utilization, and now you're paying the price for it. So, but it strikes me that Maryland is sort of in a unique position with some of its global capital. You know, I mean, we have things where that works to our disadvantage, but is this not, I guess I'm wondering is, well, there's two things. One, are we in a unique position to at least experiment the way you kind of laid out there? Are there not things we could do here to figure out some way to protect the taxpayer and the, you know, private insurance subscriber from bad behavior? And why would we limit this only to oncology? Isn't there a number of areas where you would, that self-referral kind of, those bans have come into question of, is that really, you know, just not the way medicine is practiced anymore, and therefore, you know, you're constraining them under old rules that made perfect sense when they were implemented, but that's just not the reality that's faced today.
Yeah, I mean, and I think the most telling illustration of that is if you look at both the OIG and the GAO work of late, post sort of advanced payment adoption, the old excessive use, overuse of certainly imaging diagnostics. They're not doing those things anymore because we sort of recognize things have moved on. So to your question, yes and no, that under the new model, the state does have the ability to request care, what are called care redesign amendments. That would be basically, as the term would suggest, amendments to the all-payer model. We have two of those in place currently, one of which is a chronic care improvement program, which allows hospitals to provide funding to community-based providers, basically shift Part A dollars to Part B providers verboten under Medicare historically, but that allows us to do that. That has been approved in about, next year, FY 2019, I think we think about half of the hospitals are going to be joining that program. They also have a more popular program, which is called the Healthcare Improvement Program, which allows the creation of certain hospital-based bundles in which, again, under the same theory, Part A dollars can be shifted to Part B providers in some instances. So, yes, but it's a very slow approval process that has to pass through CMMI. We can't sort of self-approve these projects, that they have to be approved on a one-off basis. That same sort of provision will exist in the new model, should it be approved shortly. But I think the flexibility is there. And in fact, there is a group of stakeholders meeting broadly, including largely under HSDRC and the department's direction, talking about new models that could be entertained. Certainly one that we are encouraging is collaboration between post-acute and hospital providers. So we think there's a lot of opportunity. Certainly commissioners, if you have ideas and you want to push them forward, I think that'd be a great vehicle to do that. The timing is really a bit frustrating that these things take a long time to get through CMS, and they also require participation contracts that typically everyone looks at pretty carefully before they sign.
Then on this issue of payment, I don't want to drift from the from what we're doing here, but you just brought up something really, I think, very important, and that is about a year and a half ago, we submitted a big report to the state legislature on the state of palliative care in Maryland hospitals. It was very well received, from what I understand. Nikki, I know that you're interested in this because you've done work on the advanced directives. But looking at the existing Medicare program around the country, we're not talking about hospice care. We're talking about palliative care, where there is maybe a hope for recovery, but you're talking about very seriously ill people who may not make it and going into before they go into hospice care. The difficulty seems to be that, today with Medicare, palliative care services, which are almost entirely team-based services, require, under the current system for Medicare, it's reimbursement according to standard Medicare rates for services from both A and B. And this is largely disjointed and fragmented. Frankly, it's very cumbersome, both for the doctors and the patients. Now, my question is simple. I don't want to take us too far off, but the question here is this. Is there, under our authority, under Maryland's waiver authority, under the all-payer system, do we have the capacity, for example, to create for Maryland's patients a bundled care payment system, say for palliative care? As an example.
No.
We do not. Okay.
Not without, we would have to go through this process of
getting a waiver from
every. It's my understanding that everyone is a one-off exercise. We don't have like a blank check here.
All right.
Drawing this and
that was my question.
And in fact, what the physicians complained that, going back to the oncology care model, which has been reasonably successful, that actually they are hindered by the all-payer model because there's certain types of models available in the rest of the country that Maryland is not eligible to participate in. CMS's thinking is, we're building health reform in Maryland largely from the standpoint of hospitals on down. We went forward with health reform based on the system we had, and I think physicians raise a good point, or ambulatory care generally, that things that have been shown to work nationally are not available here because of that restriction. I think in the next phase of the model, that's going to be relaxed, in part because all the healthcare economy, at least on Medicare, is going to be subject to the constraints, and we'll not just be worried about constraining total inpatient, outpatient expenditures, but the total budget. So I'll talk to you afterwards about this. Okay. And I'm not going through all of these. This is a quick rundown. Really, you can review those and in some detail see sort of where things stand. But aside from the disappointment on the deregulation of acute drug inpatient rehab, we're moving along pretty well, given the enormity of the legislature's duty this year.
Thank you very much, Ben. Okay. Ladies and gentlemen, next item is the healthcare quality report for Maryland. Maryland law requires the commission to develop systems to evaluate and report on the quality and performance of doctors and hospitals, medical facilities in a comparative and an objective fashion. Teresa Lee, who is the Center Director for Quality Measurement and Reporting, is going to provide an overview of the quality reporting initiatives for the Commission, and will showcase some of the new information and some of the expanded features that have been just added to the Commission's consumer website. So, Teresa,
Thank you. And I'd like to introduce my colleague, Courtney Carter. She is the Chief for Hospital Quality Initiatives, and she will be presenting with me.
Thank you. Thank you, Courtney.
So what we'd like to do today is two things. One is to provide the demonstration of the new features that have just been added to the website. But we also want to provide a brief background in light of the interest that was expressed, I think, at a couple of commission meetings ago about a few of the commissioners would like to come together in a work group setting to begin to look at quality and create a focus and determine how we can make a better impact, if you will. So we thought that we'd provide some background for you in the context of the interest that you have. And then we'll, at a later date, set up times to begin talking about how we want to move forward with that. So as the chairman said, we have Maryland statute that directs us to collect information to provide to consumers on the performance and quality of providers in Maryland. And as you see here, this dates back almost 20 years to the commercial health plans and then the other settings that are listed. This slide provides a graphic presentation of how things have evolved over the years. Again, very high level. There are a couple of other slides that go through various changes that have occurred over time. I'd just like to draw your attention to the hospital guide, which started in 2002, and then later in 2009, we created what we called a quality measures data center. And at that time, we created a parallel system for collecting process of care and HCAHPS measures. That was when the HCAHPS measures were first introduced. We were having difficulty getting the information from CMS. So HSCRC wanted to use the information for their quality-based reimbursement program. We wanted it for quality reporting. So we spent several years with this data center. And then later, after there is so much change in the reporting, we redirected those funds to create what we have now, and that's the more comprehensive quality measures data set. Slide 3 and slide 4, again, shows the various changes that have occurred both with hospital reporting and long-term care reporting. Again, we focus a lot on hospitals, but our jurisdiction covers quite a number of provider categories. So as I mentioned, we created the new comprehensive healthcare quality reports website, pulling together all of those discrete activities into one setting. And we're now going to just provide a brief overview of recent enhancements made to the website. Particularly, our director directed us to enhance the price transparency piece, the hospital's price transparency piece, so that it would include a breakdown by payer of the hospital charges. So we'd just like to show you real quickly how that information is displayed now.
So the first demonstration I'll give you is for our price transparency update. We've actually reported price transparency for a couple of years now, but as Teresa mentioned, we have the by payer option. There are a few ways to get to that on our website. Right here in big bold print, it says the price transparency page. And the more traditional way, we can go to the hospital guide and then go down to our price transparency option. So this landing page gives background about the data that we're presenting. It's from the HSCRC inpatient data file, and just a little bit for the consumer so they understand what they're looking at. So here on the right-hand panel, we've got 3 different ways that we can view the data. So I want to go through each of those quickly just to give you an overview. So the first top, or the top view we can look at is medical conditions and charges by all payers. So this will give you statewide data. So up here we can select our time period. So I'm just going to go with the most current data period that we have. We also have full calendar years and years past. So this is what you'll see when you click on the price transparency data page for the all payers. It gives the top medical conditions and the APR DRG groupers. And you can also find the number of cases, the average charge per case, and the average length of stay. These are all sortable. So if you're just interested in the maybe average charge per case, you can click here. You can see here that the infectious and parasitic diseases, this condition is very expensive. If you want to see what some of the cheaper conditions are, you can click again, and we see that normal newborn is about $2,000 per charge. So if you want to expand on this, I'm going to just look at knee joint replacement as an example. You can click on this arrow, and then this will give you the breakdown by hospital. So up here we've got about a little more than 10,000 knee joint replacements in 2017, the first 3 quarters. And then down here you can really sort and see where which hospitals are these procedures happening at. So if I sort by number of cases, we can see that Anne Arundel Medical Center, they made up about 10% of the knee joint replacements last year. So this is a feature we've had historically. So our new feature is now by payer. So if I click the by payer tab, now we can see these knee joint replacements and who's paying for them. So if I sort by the number of cases, it's not really surprising. Medicare pays for over half of the knee joint replacements that happened last year in 2017. So the second view, we can go up here, and then this is really looking at the data at a hospital level. So if you're interested in a certain hospital, you can select one. So I'm going to select Anne Arundel, just because they were the top knee joint replacement hospital last year, and I'll stick with the same 2017 data. So this knee joint was their top 4 condition last year. So if we expand here, now we can break down by payer at the hospital level. So you can see the number of cases and the percent of the hospital total here. And then finally, we can break it down by payer overall. So if you are on Medicare and you don't really care about how much it costs to deliver a baby or have a C-section, you can select your payer type. So we'll stick with Medicare. So maybe you're interested in, we'll look at knee joint replacement again. And then now you can see at the hospital level some of the different statistics, some of the number of cases, the average charges. We can sort here. So this would be the lowest, University of Maryland St. Joe's Medical Center at 17. And then if we click it again, the highest is 142,000 at Hopkins. So it really gives you a good idea of the range of differences and how expensive the procedures can be at the different facilities. And I will pause for questions. I know I went through that a little quickly. It's a lot to digest.
Commissioner Thomas.
So like any database like this, it can shine light or it can obscure. So here's my this is a simple question. It's a knee replacement. Let's stay with the knees. Let's assume that there's no complications, just a knee replacement. Why would it cost more at Hopkins versus your lowest provider? Now, if you don't know, you're just saying, we're just sharing the numbers, then that's another study for us. But it begs the question when this data goes up like this. You're using average, which potentially can obscure, the outliers, versus a median or a mode. So one just wants to think about that, given when this kind of information goes up, there will be naive questions like mine that have broader implications that may or may not be appropriate. But it begs the question for me right now. Now, if you say, well, the best outcomes are at the most expensive place, that's different. But none of that's there.
Well, just so you know, this the methodology that we're using for presenting this information is the APR-DRG, and the system for risk adjusting, if you will, to take into consideration those outliers is embedded in this methodology that we, when we took the function of providing the price transparency on hospitals over from HSCRC, and we did that in 2014 because previously they provided the top 15. when we took that over, we worked with them to make sure we implemented their process and their methodology for providing this information. And their pop-ups at the top that will give the viewer a better understanding of how we come up with these and what adjustments are made. So your question though as to why Hopkins is higher than another, we could look at whether the length of stay was higher, but the bottom line is they are charging the rates that have been established by, right, the cost review commission, based upon the cost of the allowable cost of the hospital. So am I missing? I'm trying to read your expression.
Well, that means that the cheapest one didn't negotiate well, or what?
No, it's not a negotiated rate. It's based upon the cost of the hospital. So
So they are in a lower cost of living.
Not only that, but it talks about their wages, salaries, and you are really getting into hospital rate setting when we.
Oh, we pay the doctors more at the highest.
No, it has nothing to do with doctors. It only includes the hospital cost, which excludes any Part B cost.
Okay, I'm a patient or I'm a caregiver. Where do I send my mother? All things being equal.
All things being equal, you would look at cost perhaps. You'd also look at the infection rate for knee replacement at Hopkins compared to other hospitals. You can do those things. And if you see that the infection rate is no different at Hopkins than it is at a less costly facility, you perhaps can make a decision to go to the less costly facility.
And
Well, go ahead. Look at the Hopkins one here. It's like 2 cases to state for an average of 2 weeks, too.
Right.
I don't know how we tell people to interpret the numbers, but if if you're looking at that and you go like, well, there are 2 cases they were 2 weeks, that's probably not comparable to somebody that's got a 4-day average stay in 60 cases. Like there's like different things. I'm not sure how you parse that.
Commissioner Peters.
So when you say where you send your mother, so many things would go into that. How sick is your mother? How many other comorbidities? Is this a revision of a knee replacement? So all of those ideas have to go into this cost and this number. And if you have a very complicated case, you're more likely to send your mother to a facility who does complicated cases, who then will have a higher pay to start with. So many things will go into that. You cannot judge by this website.
So,
Director.
It's probably, I mean, this is, there's so many things you can say. And probably both commissioners made really valid points. But it's an illustration, and we could go back here and look at this in 2013 and 2014, and what you would see is that Hopkins and University of Maryland Medical Center were performing a lot more knee and a lot more knee replacements back then, and as in part as a result of diffusion of technology, but in part as a result of the new model itself, that the systems have chosen price platforms that have lower GBRs. And if you do a quick sort now by low cost, if you could do that, Courtney, you can see that lo and behold, that's by high cost. I'm not sure what you sorted it by, but okay. But you'll see that University of Maryland, St. Joe's is right up there. Hopkins Bayview is right up there, and they've migrated those services, those procedures, to basically what in the old parlance would be considered community-based hospitals that have lower GBR and lower price platforms to deliver those services. So as Dr. Peters observed, probably and Commissioner Sargent, what's left over at the academic centers is largely probably reduced infections, very complicated, very sick people that are just ending up there. But so when we educate consumers, it's really there. Most people are not going to be presented with Dr. Thomas. You can either go to Hopkins main campus or or St. Joe's, as you choose your physicians, you're looking at St. Joe's and Bayview, or St. Joe's, Bayview, and Union Memorial. Union Memorial is probably fairly, they do a lot of them too. And those would be the choices now when we're delivering those services. What, philosophically, from my vantage point, we are, the large academics are largely being priced out of the common procedure arena due to the fact that these can be done chiefly elsewhere. And we're likely to see that happen with other services for large academics, and we'll leave it to people with a lot more intelligence, and me anyway, that how do these academics survive in the world of the need to provide low cost services, and yet sustain medical education. Do you need a commission for that? No. And direct medical education, and that's the short answer. But you can see that, and if you did this in a progression, and this is more of an assignment for your students to look at what's happened for commonly performed procedures, even in this very simple consumer tool, you can see it pretty clearly that it's being migrated to community-based hospitals. So when you're choose between the community hospital, it's probably not wise to care about cost to go to the large academic.
Right, so if you have that high copay or deductible, it will drive you in where you would want persons to go, to a lower cost hospital. But this is the data, these are the results. Sorry. Not here, right, not here, but that's sort of one of the things that we want to talk about is how do we evolve the website further. So we do have, as I said, HAI data, infection data, and we have infection data for hip and knee. So we can, going forward, as we continue to sort of modify and update the website, pull that together so that you can actually see it at the same time. Not to get into the weeds, but you may recall that we're using software that was developed by ARC. It was free software to keep our costs down. And our contractor, AGS, has really been very creative in trying to work with it, maneuver it, but we'll continue to think going forward, how do we integrate the data a bit better?
The only point I was going to bring up is when you look at the, early, not your earlier, but when this kind of price transparency started coming out, I mean, part of this is nice because you are seeing this clustering, and there's a little bit, maybe a 10 or 15%. You can go length of stay, and you can do these. It used to be that you'd see like these massive differences in price. Mostly our friends at the academic medical center charging twice as much as anybody else. You see, a little bit of case mix difference, a little bit of quality, but you'd see massive price variation that didn't seem to have much to do with quality of care, difficulty of case. And so there's sort of good news here of, we see a variation here. We see that some, if you have harder cases, you not only, you keep them in longer as well. They're not ready to go home as fast and things like that. So this is, to a certain degree, you're kind of going, what's the difference here? 10 years ago, we'd look at this and go, holy moly, why is it 3 times as much? The Harvard guys, what are they charging for? And you'd realize they were charging because there was an H and an A, and it was just rep. And so this is a good outcome in many, many ways.
Merely because the name is Harvard does not necessarily mean that you're going to have the best outcome.
Right. Harvard Bethesda is, right.
Got it. Any further questions? Anything at all?
Okay, so I think my next topic will be a little less controversial. So a new feature we have on our long-term care guide is we've actually got 2. So find a home health agency, which I won't really demo because it's pretty self-explanatory. You can search by the name, the counties, or star rating. But our other feature is the home health quick compare. So this allows you to really compare home health agencies based on the consumer rating or their quality rating. So if you are interested in a home health agency and you want to look at them by star rating, if you want to see 5-star agencies, you would select that and run your report. And then this would give me all of the home health agencies in Maryland that have a 5-star rating for either their consumer rating or their overall quality rating. So that's one way to search. Another way is, yep, we can do that. So if you just want to see 1 to 2 stars, you would run your report.
There's a lot of pushback on that, the methodology associated with the star rating. I mean, you're going to get that too.
They would not be in the room if you were in the room. I'm just telling you. Everybody's got your number.
So if you're interested in just searching by a facility by, or an agency by its name, you can select from our drop-down menu, or you can type it in. So I'll just randomly select Amedisys Home Health of Greater Chesapeake. So when you click on that agency, you'll get to their profile page with just some resources on this left-hand panel, their address, you can get to their website. And then also, you scroll over, you can see their overall consumer rating. And as we showed you earlier, these question marks are little pop-ups, and that can give you more information about the data that this conveys. So if you want to dig into their quality measures, we'll just click on quality measure. And this gives you the overall quality rating, which is different than the consumer rating. And if you want to look at the specifics, you click on show measures. So this will tell you about the measure, and then this will give you the home health agency rate compared to the state and to the national. And then if you want to go to the consumer ratings, we'll just click here. Again, it's similar. It'll give you the star rating, the home health agency rate compared to state and national. And if you scroll down to, you can see what counties that they're authorized to serve in. So this particular agency can operate in Baltimore City County and some of the nearby areas. So finally, you can also, if you're just interested in a home health agency that will serve your particular county, you can click on County Serve and then select, so I'll select Baltimore City. And then these are all the home health agencies that are authorized to work in Baltimore City. And then again, you can get to each profile page by selecting on the home health agency for more details. Do you have any questions on that?
Okay. Let's hit a few more slides, and I won't go through those. It's just basically talk about how things have changed over time, and we're now trying to really keep up with all of the websites that are out there. When we started, our website was probably one of the first. The hospital website, the long-term care website, there was one specifically, there is one rather for health plans, et cetera. So there are so many other sources of information. A number of the sites are using the same metrics in the different ways. And then, of course, there's a shift to outcome measures, and price transparency is going far beyond just what's in the hospital to the episode of care as displayed in the new Where the Cost, our new Where the Cost website that came out last year. So there's a number of changes. So on slide 7, we have been trying to streamline throughout the process and then use the funds from savings to now promote the guide and to just be more efficient in how we move forward. But we really want to try some to determine if there is a way that we can also go beyond public reporting and also do more in terms of facilitating quality improvements. And I just had some options here that we wanted to, for example, I think that Dr. Thomas, we talked about having an internship program, a more formal program. When we hire, we have another vacancy to fill. That will be a formal role that they play. Because otherwise, we won't be able to get it done because there is so much out there. But I think to the extent we can begin to determine how we use the quality data that we have, how we can establish these relationships. You've heard a little bit about what we've been doing with on the outpatient side, which Yana provided an overview a couple of months ago with MASA. We work with MHA. We want to continue to do those kinds of things. And then on slide 8, we just formulated 3 questions, not to be answered today, but just to think about as we come together as a small group. And that's how do we make optimal use of our resources? How do we use our data more effectively to inform consumers? And how do we proactively identify problems? because we want to respond when we hear that someone is left out on the street at night, or we have this ambulatory surgery issue, or we don't have it, but there is one. How can we be more proactive to anticipate that, or to follow up to see, do we have a problem in Maryland? Is there data we have that could help influence our understanding of problems that come about? So that concludes the presentation, and hopefully when we have our first meeting or discussion, we can come up with some targeted activities perhaps, or at least we would like to know that the direction that we're going is the most appropriate for what our mandate provides and what our resources will allow.
Thank you very much, Teresa. I just want to expand. I think many of the commissioners feel the same way I do. I think the work that you guys have done on quality measurement has really been outstanding. We have made real progress in this area. I just wanted to, whether you know it or not, you should know it. For example, in the whole area of price transparency, I got a letter about a week and a half, 2 weeks ago, signed by Claire McCaskill, Senator Claire McCaskill of Missouri, and Bill Cassidy of Louisiana. In the United States Senate right now, there is a bipartisan working group on promoting price transparency, how to actually accomplish this. Because what we've tackled is sort of, everybody understands it's a national issue. And but what I felt was quite interesting was the fact that the senators cited the progress of Maryland, in particular, our efforts with Where the Cost as a major breakthrough in price transparency. Today we've learned a couple of things. I mean, we know, for example, that Maryland is actually leading the country in cyber protection of healthcare data, and this is another, I think, star for us. I don't think we blow our horn loud enough in many cases. We are doing some very, very fine work here, and I think it's critical that certainly members of the state legislature and members of the Maryland media know exactly the work that the commission and its staff is doing. So thank you very, very much for this excellent work.
Thank you. But could I clarify something, because I think there is some
Sure.
confusion.
Let's
Where the Cost is a new initiative that was developed under Linda Barnitska Center.
Yes.
So I really want to make sure that
Yes.
that's clear and give her kudos. And
Absolutely.
there you are. So our work is really in quality with the hospital price transparency piece.
Right.
But the price transparency, the new effort that has just recently come out last year, Where the Cost, is actually Linda Barnitska.
Yes,
so
that's correct.
We really should get that straight.
That's right.
All one MHCC.
That's right. We all are. One big happy family. Listen, I really mean it. Well, Linda knows this. We have been talked about this. I just think it's absolutely wonderful that Maryland is leading the country in some of these initiatives. We have a long way to go. We have a long way to go in quality, especially with hospitals. We all know, we got the rough news, earlier in the year about how hospital patient quality and patient safety is where it stands. I mean, for a lot of us, it was a shocker, but we're going to make improvements here. We're going to get very serious about it, and we're going to work cooperatively with the private sector, with our friends in the hospital community, to help them do the very best job that they can do. That seems to me a major function of the commission. Yes, we're a law enforcement agency. We're a regulatory agency. We're a judicial agency when it comes to exercising our determinations about whether or not to grant a certificate of need. But this agency, in my view, should be an agency that is friendly and cooperative with our private sector friends and providers. So anyway, I want to get off the soapbox here, but I just want to tell you how much we appreciate the work that you're all doing in this area.
Thank you.
Okay. Ben, you've got to tell us what the upcoming initiatives are.
So in April, one of the things that we also keep in mind to the to the point that you made, we will likely see the next leapfrog report. I think that's due in April. Is it not? It is. And actually, we probably are not going to see yet significant improvement from Maryland hospitals. In fact, that was in the proverbial can before the November report came out. So we're still catching up on quality, but at some point over the next year, we'll hopefully be able to see some impact due to our efforts and those of others in really raising awareness on quality. In terms of the agenda for April, we'll have a report from Ken on the privately insured. That's an expansion on a report he gave you in February on the individual market only. We also have this will be a fairly busy CON month. We'll have at least probably 3 CONs to consider, including very likely a significant one. The staff doesn't like me to pre-stage these announcements, so I'm not going to name them, but there'll be 3 significant CONs. We'll have a new telehealth grant award coming out. This is the one on our work to promote use of telehealth for medication management and medication reconciliation. That will present those winners, and we'll also present the final vendor criteria for our advanced electronic advanced directory initiative. We'll also have a rundown on what the final outcome was with legislation. Likely give you a preview, given that it's likely we'll have a couple more studies to do, the study on infant mortality, and begin to lay out plans for doing that. So look forward to seeing you all. I appreciate, I want to just take this moment to thank the chairman for his advocacy for the commission. He's a person who can reflect on the commission's past without any trepidation, because he's really confident of the future of the Healthcare Commission. I think that's really commendable. I think the staff really appreciates it a lot.
Thank you very much. Well, all good things come to an end. So, hey, look, the world is finite, time finite. Do I have a motion to adjourn? A second? All those in favor say aye. Ayes have it. Okay, let's get out of here.